Díagh Fáilteoibh go dtí an nuamhrach inniu. My name is Ciaran Staunton. My wife and I are co-founders of Sepsis, the legacy of Rory Staunton. I am one of the US representatives on the board of Global Sepsis Alliance. I have the honour of welcoming you here today. Those present, we are here in the shadow of the United Nations building. And from those watching around the world, this is an extremely prestigious event. The number of countries here is largest number ever. We are bringing sepsis and the issue of sepsis to every part of the world today and to the world leaders, because we know that most sepsis deaths are preventable deaths. We know that sepsis is the largest killer of children in the world. But I'd like to, before we start, just thank some people who made this event possible today. First and foremost, we are holding this in Northwell Health facilities. Michael Dowling, of course, is one of our champions who made this possible, and also Dr. Peter Silver. We also couldn't have put this put together without the people who are here doing the homework. Norma Sanchez has been working here all week. Melvin, Peter, Victor and Arnold. People who have worked around the clock, free of charge, to make this possible. With that, it's an honour to welcome to Manhattan the CEO of Global Sepsis Alliance, former chair of Parliamentary Committee, and former Deputy Health Minister of Georgia. Please welcome Dr. Mariam Jashi.
And it would never be possible to organize this event without your leadership and the very close collaboration throughout the preparatory process. I'm absolutely delighted that today we are joined by truly distinguished global health leaders and thought leaders in health policy. And this is a reconfirmation that the sepsis agenda is moving forward every year, every month, we are joined by the experts, policymakers, decision makers that can truly make a difference. And the difference we are planning to make, and we hope to make, is to implement the 2030 Global Agenda for Sepsis, the very first multi-year global strategy for sepsis that we launched at the German Parliament last year. And through implementing this agenda, every year we can save 2 million lives from sepsis. We don't have any other cause that can have this impact. And the numbers speak for themselves. 1 in every 5 deaths, 20% of the global deaths are related to sepsis. And this is the only event among 300 and more side events of the UN General Assembly that discusses sepsis. I really hope that with the support of our leaders and our colleagues and friends, we can change the status quo and we can position sepsis where it deserves to be in global political agenda and truly make sepsis the next success story in global health. Without further ado, I would like to ask Marvin that we hear the special video address of Dr. Tedros Ghebreyesus, the WHO Director General, for the 2025 World Sepsis Day that we are celebrating throughout the month of September. We are extremely honored by Dr. Tedros' support.
Dr. Mariam, Jashi, Dr. Tex Kissoon, dear colleagues and friends, there are almost 50 million cases of sepsis and control measures, early diagnosis, and rapid treatment. WHO is working with countries and communities to strengthen health systems to reduce the impact of sepsis. We have guidelines on reducing bloodstream infections, and we will soon publish guidelines on the prevention and clinical management of sepsis. We're also studying research priorities for maternal sepsis and how to reduce antimicrobial resistance, which undermines our most powerful tools to combat sepsis. Through WHO's Acute Care Action Network, we're working with 80 partner organizations to implement tools shown to dramatically reduce the deadly impact of sepsis. I thank the Global Sepsis Alliance for your leadership and partnership, and all of you for your commitment to preventing and treating sepsis. Because nobody should die while seeking care. I thank you.
Of course, Professor Kissoon and I are extremely honored to be addressed personally by Dr. Tedros, but without Professor Konrad Reinhardt, who was the founding father of the Global Sepsis Alliance behind the World Sepsis Day movement, the World Sepsis Congress, and the World Health Assembly resolution, nothing would be possible. So, Konrad, special thanks to you and special appreciations of all your leadership for this. I have an absolute delight to introduce you Her Excellency, Dr. Hanan Al-Kuwari, the advisor to the Prime Minister of the State of Qatar, the former Minister of Health of Qatar, who has been the driving force behind the success of sepsis response in her country. And it's an honor, Dr. Al-Kuwari, and we look forward to hearing your statement and intervention.
I'll do like you, Mariam. Thank you very much, Dr. Mariam. Your Excellencies, distinguished colleagues, ladies and gentlemen. It's an honor to join you today and discuss with you one of the most pressing yet under-recognized global health challenge, sepsis. Sepsis is more than a clinical condition. It is a silent emergency affecting millions every year. According to the World Health Organization's, nearly 50 million people develop sepsis annually, and it is responsible for almost 20% of all global deaths. Its toll is especially heavy amongst the most vulnerable: newborns, children, pregnant women, older adults, and those living beyond the unacceptable human loss. Sepsis imposes a profound economic and social burden. Survivors are often face life-changing complications, from physical disabilities to cognitive impairment, which can last for years. And yet, despite its scale, sepsis often remains marginal in the global health discussions. Following the adoption of the World Health Assembly Resolution, WHA 70.7 in 2017, a few countries, including my own, initiated the implementation of the resolution through the launch of programs to strengthen prevention, early detection, and management. These experiences have shown us that a coordinated, system-wide approach works. Regrettably, by the end of 2024, only 10% of countries had national programs in place. For example, in Qatar, the National Patient Safety Collaborative, launched in 2018 in partnership with the Institute for Healthcare Improvement, brought together 19 teams from leading health institutions, from Hamad Medical Corporation, Primary Care Corporation, Qatar Red Crescent, and Sidra Medicine, in a collective mission to improve outcomes. The model combined leadership engagement, evidence-based clinical pathways, and robust monitoring through a central dashboard. Shared learning platforms, such as the so-called Al-Majlis Forum, helped build a culture of continuous improvement. Through this innovative framework, overall mortality due to sepsis decreased by about 50% over the last years. In particular, among the participating institutions, Sidra took a bold step, setting the target of 0 preventable deaths from sepsis. Through staff training, public awareness, standardized early recognition protocols, and the integration of digital tools, that goal was achieved in 2024. Importantly, it was achieved not through isolated interventions, but by embedding sepsis prevention and care into the daily functions of the health system, showing Qatar's commitment to system-wide, data-driven, and collaborative approaches to combat sepsis and improve patient safety. As pointed out at this event, sepsis is not just a complication of infectious diseases. The link between sepsis and non-communicable diseases is significant and bidirectional. People living with non-communicable diseases such as diabetes, cancer, cardiovascular, and chronic respiratory conditions are far more susceptible to infections that can lead to sepsis. Conversely, surviving sepsis can lead to the development or worsening of non-communicable diseases, often creating a life cycle of illness and ill health. This makes sepsis an essential consideration in any non-communicable disease strategy, and a barrier we must address to achieve Sustainable Development Goal 3 on health and well-being for all. The connections also extend to other global priorities, such as antimicrobial resistance, maternal and child health, universal health coverage, and pandemic preparedness. The AMR crisis magnifies the sepsis challenge. Drug-resistant infections already account for millions of sepsis cases each year, particularly among susceptible population groups. Indeed, in Qatar, we undertook a research project involving both health and academic institutions to address the link between sepsis and AMR in immunocompromised patients. Without strengthening antimicrobial resistance, investment in rapid diagnostics and new antimicrobials, as well as a health system capable of timely, evidence-based care, we will not reach a sustained progress in this undertaking. So in summary, what can we take away as lessons learned so far? Several points are clear. Leadership matters. Political commitment is essential to sustain investment, drive awareness, and hold systems accountable. Awareness saves life, public campaigns, and professional education must empower both health workers and communities to recognize and respond to early signals. Integration works. Sepsis prevention and management should not sit in isolation, but be embedded within non-communicable disease programs, AMR strategies, and health system strengthening efforts and routine operations. And finally, data drives improvement. Transparent, real-time monitoring and feedback enables rapid course correction and sustained progress. Dear colleagues, no country is immune to this problem. Whether high, middle, or low income, all nations face the challenge of ensuring timely recognition and treatment of sepsis. The approaches may differ, but the underlying principles are shared: awareness, preparedness, and resilience. Today's event is an opportunity to turn knowledge into momentum. We must bring sepsis into the mainstream of global health dialogue as a cross-cutting priority that affects our success on multiple SDG targets within a renewed multilateral and international collaboration. If we succeed, we will prevent avoidable deaths, reduce long-term disability, and protect families from devastating loss. We have the evidence, we have the examples of success, and we need to expand a growing coalition of committed actors. What is needed now is the will, the political, professional, and societal will to act with urgency and unity. Thank you very much.
To all the incredible credentials of Dr. Al-Kuwari, last year when I attended the executive board meeting of WHO, I was truly impressed by the leadership of the chair of the executive board. That was Dr. And these words coming from you mean so much for us as the global community trying and investing all possible efforts to make a difference. And I'm sure with leaders and support from the distinguished policymakers like you, I'm sure that the success will definitely come. It takes time, efforts, but it will of course be there. I have an immense honor to introduce you to Mikheil Sarjveladze, His Excellency, the Minister of IDPs from occupied territories of Georgia, Minister of Health, Labor, and Social Affairs. He has a vast portfolio. And I'm delighted that as the former Deputy Minister and the legislator of Georgia, I'm extremely proud of the achievements of Georgia in universal health coverage, in hepatitis C elimination, the NCD progress that was further improved by the leadership of Minister Sarjveladze, and we look forward to supporting this new global cause.
Excellencies, distinguished colleagues, ladies and gentlemen, first of all, let me reiterate that it's my great privilege and great honor to be here today, to be invited, and to have opportunity to discuss this very, very important topic together with you. Unfortunately, I'm really sorry not being able to attend this meeting wholly, but of course, I want to first of all underline the importance of this kind of cooperation, and thank you very much for this great, huge opportunity. Looking forward to future cooperation. It is really an honor to join you today to address a topic that remains too often overlooked in global health: the hidden and devastating link between sepsis and non-communicable diseases. In Georgia, as in many other countries, we see how conditions such as diabetes, cardiovascular disease, and cancer make people more vulnerable to infections, which can lead to sepsis. Conversely, sepsis survivors frequently experience long-term complications that increase their risk of developing or worsening NCDs. This bi-directional relationship highlights an urgent need to integrate sepsis prevention, early detection, and treatment into our broader NCD strategies and universal health coverage reforms. All those numbers were reiterated here today, so there's no need to once more to underline the importance of this kind of approaches. Georgia has taken important steps in this direction. Through our ongoing health reforms, we have strengthened access to chronic and cancer care medicines, expanded primary health care, and enhanced hospital-based emergency care. These reforms provide a foundation for more integrated approaches that link NCD management with sepsis prevention and response. As we look to achieve the health-related sustainable development goals by 2030, let us recognize that we cannot reduce premature mortality from NCDs without addressing sepsis. This requires political leadership, as it was mentioned here today, cross-sectorial collaboration, and global solidarity. On behalf of Georgia, I reaffirm our commitment to working with partners to scale up awareness, first of all, strengthen health systems, and ensure that sepsis is fully recognized as both a global health and development priority. Together, by bridging the gap between NCDs and sepsis, we can save millions of lives and build more resilient health systems for the future. I hope that we will have further opportunities, more intensified working together, just to be more successful in this respect that was mentioned here today. I wish you all fruitful discussions and wish you good luck in fighting against sepsis. Thank you.
Minister Sarjveladze, thank you immensely for making time out of your extremely busy schedule. We know that you have to soon leave for another commitment, but hearing and reaffirming the commitment of the Georgian minister is extremely important, given the traditions of Georgia having one of the first national sepsis centers in 1979. And I hope that before you leave, I would like to appeal to you and Dr. Hanan that we start working possibly together and mobilizing other UN member states for re-initiating the World Health Assembly resolution for sepsis, and also maybe next year we can have the official side event on sepsis in the UN building, because this global health threat Thank you very much again. We are honored to be joined by Honorary Alan Donnelly, the convener and chair and founder of the G20 G7 Health and Development Partnerships, one of the strongest dialogue platform between legislatures and executive branches. And Alan has been a friend of the Global Sepsis Alliance since over the last few years, and we are truly delighted, Alan, that you could join us today, and we hope that we will strengthen our collaboration with G20, G7.
Thanks very much. This is a very strange thing, isn't it? But there we are. Can I? I might walk out with it and then you can hear all my conversations when I'm on the telephone, which politicians, of course, do. Can you hear me okay? Yeah, good. So look, my role is the chair and founder of a legacy initiative from the German presidency in 2017 of the G20, where Angela Merkel wanted to have a legacy initiative And so we created this partnership for the G. It started off as a G20 initiative and it's expanded now into the G7. And of course, Angela Merkel in 2017 hosted the first ever meeting of health ministers under the G20 umbrella, which was largely an economic activity. But of course, the Chancellor then, who is a scientist, decided that health should be on the agenda. And just a little bit of background for you, one of our global ambassadors, Agnès Buzyn, who was then the French health minister, turned up at this first health ministers meeting, and Angela Merkel had arranged a role play exercise for health ministers. And this is 2017, and what was the theme of the role play exercise? It was how do governments cope with an airborne pandemic. And what Agnès Buzyn tells me is that it was very clear that none of the governments were prepared. And we have to ask ourselves by 2020, how much had they learned by then? And clearly lots of governments hadn't learned a lot. Now Conrad is sitting here, and he's my greatest critic, but also a very good friend. And we've wrestled with this issue within the G20, G7 Health and Development Partnership of how can we really help the Sepsis Alliance. And Mariam very kindly came along this morning when we launched the global, I've left it at the desk, the Global Legislators Report on Non-Communicable Diseases. And we had ministers and members of parliament present. And it's a toolkit on how non-health specialists in Parliament can raise the issue of NCDs and mental health. And it's online, and you're very welcome to have a look at it. And one of my main jobs over the next 12 months, because I've got so much free time, is to meet parliamentary organisations. So in 10 days' time, I'll meet the Commonwealth Parliamentary Association, the Mediterranean Parliamentary Association, which is officially recognised by the UN, are members now of our partnership, the European Parliament, and the chairman of our parliamentary network, Dr. Christopher Kalila, will be with me in South Africa for the health ministers meeting. And if you have a look at this report, you will see that one of the contributors is Her Excellency Dr. Hanan, who I have to say is just extraordinary. I mean, I'm a cynical old politician, but when I meet people who are absolutely committed to delivery, then I'm incredibly impressed. And Your Excellency, you're an extraordinary person, and you're a great health leader, and thank you for everything that you and Qatar do. Now, going back to Conrad, what can we do in the G20, G7 Health and Development Partnership to help in concrete terms? Because I come from the northeast of England. I used to be the leader of the British Labour Party in the European Parliament. I'm very focused in outputs. And so, Conrad, this is especially for you, and I was hoping you were here today. At the moment, across the world, we have a shortage of at least 11 million healthcare workers. It's sort of dropping, in fairness, it's dropping. It was much more than that 5 years ago or so, but we still have 11 million, and I think it's probably more than that, of healthcare workers, particularly community healthcare workers, where, let's be frank, that's where the real work is done, where people are in low and middle income countries that have very little resources. And these community workers can either be part-time, they can be voluntary. You know, they do extraordinary things in maternal care and childcare and so forth. So what I'm going to propose, because I didn't want to just come here and blah, blah, is I think we need to look at the workforce, because I think that from the research that I've done prior to coming to this meeting today, is that the problem is, first of all, we need more people working in healthcare. but are we training people in how to recognize sepsis early enough? And there's a whole series of, and I've got to refer to notes here because I'm an economist, not a health specialist, but I want to see whether we can work together, Mariam, on this issue of recognizing sepsis, and for us to have a new health workforce initiative that I will propose to our partners that the G20, G7 Health and Development Partnership supports during the French presidency of the G7 next year, and Britain has the G20 presidency in 2027. And what we need to do, and I'm sorry, I'm going to have to refer to notes, but what we need, my son's wife, my daughter-in-law, is a clinician, but in mental health. And she said that nurses are very rarely trained properly to recognize sepsis. And so, to be very concrete, what I would like us to do within the Sepsis Alliance and within our partnership is for us to work together on something that we can campaign around. And I know it's in a number of documents that Conrad has worked on and speeches and so forth. But I'd like us to produce something that's very concise and very punchy, which looks at things like clinical tools and protocols. We've already heard about system level support mechanisms, multidisciplinary engagement, public and patient awareness, aligning policies, embedding sepsis recognition within national and patient safety strategies, which I think is very important. But what I would like us to do is to work in very concrete terms on those issues that are related directly to healthcare workers. Because in my view, if my granddaughter who's 8 and goes with certain conditions to our local hospital, I want to make sure that a nurse or the triage system can recognize immediately that there's something wrong with her. I don't want the phone call when I'm traveling around the world to be told that something tragic has happened because the health system didn't work. Now, you can't blame the health professional, because we've also checked this out in terms of the research that we've done on this. And in many places, sepsis is not part of the core curriculum of healthcare workers. I find it really bizarre, but it's not part of it. But it's not only those in rich countries where this has to happen. When we're talking about community care workers, we've got to find a way, using digital technology, to make sure that they understand this. We also need education for the public to understand that there are certain basic symptoms that if that symptom occurs, they must go immediately and they must be seen and treated properly. So what I'm offering, Mariam, because you've got so much energy and you're doing a wonderful job, is I've looked very carefully at how can we focus on something where we can work together on this. And I really want to help because, as Conrad repeatedly told me, that during COVID, although the deaths were COVID related, in fact it was sepsis in many cases, and I always remember you telling me that. So let's look at something to do with workforce training, not just people who get a degree or whatever, but how can we use digital technology to feed through the system? How can we work with the health ministers who are at the launch of the Legislators Initiative today? How can we talk to those legislators for them to take this message back to the community and make sure that we build into the education and training system for either full-time or even voluntary healthcare workers a recognition of how you spot sepsis and how you intervene quickly to deal with it. And that also, by the way, involves working with pharmacies, because often people will go to a pharmacy as the first port of call, and we need to make sure that when it comes to self-care, that people do this. So it's an offer of something concrete. We will work with you on it. I know that Her Excellency Hanan will help us with it, as will other people in this room, and thank you so much for your time.
Alan, I truly couldn't ask for a better dialogue, and it's like an open, frank, honest, really searching for solutions that we can find together. And 2 days ago, Alan, I was honored to join the panel together with Dr. Jarbas Barbosa with the Saudi Commission for Healthcare, specifically discussing the workforce challenges. And definitely, we can work closely and identify very specific health workforce capacity building initiatives that can really make the difference. Because if Australia halved the deaths from sepsis, it was only through training the frontline workers on the question, could it be sepsis? Just questioning in the emergency rooms whether it can be related to sepsis saves lives. So we are absolutely delighted, and we will definitely follow up very closely with Conrad on the next steps. Thank you. And our next speaker is our long-standing partner, my dear friend and colleague, Ricardo Baptista Leite, who is the president of the Unite Parliamentarians Network, who couldn't join us today. But we're delighted to have Guilherme Duarte, the executive director of the Unite Parliamentarians Network. This is the network of more than 500 current and former legislators from 112 countries. And I'm also delighted to be part of the Unite's noble mission. Guilherme, please.
Hi everyone, thank you so much for having us here. So my name is Guilherme Duarte, I'm a public health medical doctor by training, and I'm currently the executive director of Unite, actually for just 1 year ago. Previously I was in Geneva, where I was a diplomat for the Portuguese mission, and I crossed a lot with the Honourable, and yes, and it was a very, I also have a word of compliment to your guidance or guidance to the works where nowadays it's very difficult to make consensus, even in health issues. And so thank you so much for also your leadership in that role. And I wanted to pick something that you said on your intervention, which was that although we had the resolution in 2017, throughout my years there in Geneva, on the 5 years that I was there, I've never heard the word sepsis during the high-level discussions. And I think this is also something to note, and I think that is something to bring back the discussion, which I know that Mariam very successfully in 2024 with this reintroduction of the action plan will be able to promote this back into the main agenda. And I would like to also acknowledge Mariam. As I said, I'm only arrived for the first year, but since the beginning that I arrived to the network, not only as a board member, but also as a very, very dedicated champion to the cause, she in fact embodies what is exactly the objective of Unite, to promote global health champions in topics, in roles, and she is in fact what we like to call a model parliamentarian in terms of the work that she does. So thank you also for that, Mariam. You know the work that you do to Unite, and we're very grateful to have you. As you know, and I have here on my notes that last Saturday was celebrated World Sepsis Day. And I would like also to recognize that, in fact, this is now on the policymakers' agenda. At least Unite promotes this internally, thanks to the great work that the Global Sepsis Alliance is carrying out over the past years. And so I think this is a nice change of the status quo. I'm not gonna tell you how this is very impactful in terms of the millions of deaths per year. There are better persons here to say that, not as that is a costly disease or how it affects the most vulnerable. You all know this. What I'm going to, and what I can make, also in the spirit that Alan promoted in terms of action, is to say that we Unite will carry out our work to try to prioritize the action on the policymakers, but also countries as a whole, to develop sepsis protocol, train healthcare professionals, and also contribute to people's health literacy on this. And so what is the role of parliamentarians and how can we help? In fact, we believe that members of parliament must be aware of the real impacts of sepsis on their nations and their citizens, and assume this crucial role in advocating for prevention, early detection, and enable timely and effective treatment for sepsis. Parliamentarians are very best placed to use legislative and parliamentarian tools, namely voting, budget definition on internal level, to advocate for the creation of national action plans on sepsis. And then, of course, increasing funding for sepsis and promoting funding also for research and development of new antibiotics and treatment for sepsis. Last but not least, to develop better diagnostic measures where there's need and ensure the proper infrastructure and resources within the national healthcare system. Mariam already said we are a network that represents over 520 current and former parliamentarians, either in national parliament, Senate and Congress for over 120 countries, and we are a proud partner of the Global Sepsis Alliance for some years. We'd like to continue this work, to be part of this fight, to raise awareness of sepsis and support the fulfillment of the 2030 Global Sepsis, Global Agenda for Sepsis. Thank you very much.
Guilherme, thank you immensely. Again, reaffirmation of UNITE support means a lot. When we were starting, UNITE was one of my first biggest partner supporter, and that's how we made our very first relatively small scale side event in New York 2 years ago. And every year we see stronger partnerships, more friends, and we truly see the future for the global agenda. And what it means, it's not the ambition that we make the difference, but it's really the translating into the saving of millions of lives. We have the privilege of saving immense human suffering, loss, and I think that we have this unique chance to definitely not miss. Now, at the end of the opening session, I'm turning to the host organizations leaders as the Global Sepsis Alliance and the Medical Women's International Association. I would like to invite Tex Kissoon, Professor Kissoon, who is the president of the Global Sepsis Alliance and the past president of the World Federation of Pediatric Intensive and Critical Care. Tex.
Very much. I'm really humbled to be in this room. And when I reflect on when we started in 2017, we had our first sort of side meeting at the WHO. And I remember Alan was chairing the meeting at that time, there was a session, and we again had a lot of problems with AV equipment. Now, make what you want, but I think there has to be a connection. Now, and I reflect, and I'm very humbled being here because, well, first I ditched my notes because everybody said what I wanted to say already. I am never original. So the thing is, I reflect, I'm really humbled being here because I look in the room and I see the individuals, the giants on whose shoulders I stand. And I remember Conrad, working with Conrad, you heard enough about him already. We worked along for many times from the first time we started the Global Sepsis Alliance, and I've always been very proud to have him at my side. I went to Chris, Professor Murray, years ago, and over a period of time, got them to start looking at the data on sepsis, and they've become a great partner right now in helping us going forward. With Karen Staunton, we went to Ireland together, the time they were having some problems with their sepsis sort of initiatives, and I remember we spent some time helping them there, and we know what you've done here. Tom, my good friend Tom, Tom was very interested in understanding sepsis, what I was doing in Africa, so I dragged him down to Uganda, and he's had an experience like no other. So all these things have brought us to where we are here today, and all of you in this room. Now, I'll be remiss if I don't say something about the low and middle income countries. As Chris's data have shown, 85% of cases, 85% of death in those countries. And the very same issues we talk about, the sort of confluence of non-communicable diseases and sepsis, are very much present in those countries. And the consequence of that is very much more devastating. And I think we have to address those issues there for a variety of reasons. I think most of us, or all of us, I think in the room, are moral individuals, and we feel we have a moral obligation to address sepsis across the world, not only in our own areas. And if we aren't moralists, well, then there are consequences to it. And you've heard about the antimicrobial resistant issues. It is not stopped by boundaries. The very same thing with sepsis, the COVID issue, it was never stopped by boundaries. And in fact, the late Paul Farmer said very clearly, he said, and I'm paraphrasing, borders are like semi-permeable membranes. It allows the free passage of infection, sepsis, disease, but at the border stops policy, drugs, money, humanity, the things that would cure the sepsis. So we cannot look at it dispassionately in one area of the world or the other. And having worked in a lot of low and middle income countries, Alan, what you were saying resonated with me, because in Bangladesh years ago, we had a program called Interrupting Pathways to Sepsis. And it was trying to go upstream, because sepsis is not an ICU disease only. Sepsis occurs in the community. And in most countries where you have non-resilient health systems, you have to go upstream and prevent sepsis as best you can, vaccine, nutrition, clean water, et cetera, et cetera. The second thing, working in sub-Saharan Africa for the last decade and a half, what we've done is exactly what you were talking about, the issue of how do you recognize sepsis. And in fact, we just published our work, put in a triage system, simple triage system in an institution for children. We found that we decrease antibiotic use, decrease admissions, and improve outcomes from sepsis, decrease mortality. So simple things work. Also, at the other end, which I think many systems have not addressed, is the issue of post-discharge mortality. We know across the globe, 40% of adults will come back for care, and about 40% may die within a year after sepsis. In children, in our studies in sub-Saharan Africa and Asia, we found that within 6 weeks to 6 months, the same number of children who died in hospital, the same number died during this period of time. And 60% of those did not make it back to healthcare, they died at home. So strengthening the healthcare system, we have to strengthen community systems, which we did, and then we found that the referral back to hospital increased by 100% and mortality decreased by 30%. But I think that these are the simple things, and we have to look at the entire globe, not in our own little systems. In fact, I remember vividly 2 decades ago, I was in the emergency department in Uganda in one of the hospitals there, Makaruri, the children's side. And I asked the head nurse at the time, Naomi, how do you recognize sepsis? Because that was a problem we were having in our world. And she looked at me very bored and said, even a blind person can recognize sepsis. The fact is she had seen so many children, right? So the other message I'd like to say is that we have a lot to learn from the low and middle income countries. It's not a one-way, and in fact, I've said this in our global center back at the University of British Columbia, that we feel that it's one way where we are the the benefactors of others, but it's an exchange and we get as much as we give. So my message would be that I think when we think about sepsis, we need to think globally, we need to engage across the world, And I can tell you, at least from my experience, we give as much as we get. And I'm very pleased to be here. I'm honored to be in the presence of you all. Thank you very much for coming, and let's continue. Thank you.
And I would like to once again congratulate TECCS and congratulate us at the Global Sepsis Alliance that TECCS was re-elected as the president of the GSA for the next 3 years. So it's amazing working with you, TECCS, and hope by the end of the next triennium we will have more to look back and really celebrate. And as TECCS already mentioned, we have the honor of having Chris Murray in the room, and we are truly delighted that the Institute of Health Metrics and Evaluation is the co-organizer of the event. Having this logo on the sepsis agenda really means a lot. Chris, thank you very much, and we look forward to your presentation in the next panel. And I would also like to acknowledge all our partners. Sepsis Alliance, thank you, Tom. American Medical Women's Association, Dr. Eliza Lochin, the CEO, thank you. Virchow Foundation, Roland Goethe, the dearest friend and colleague. German Health Alliance, Sepsis Stiftung, Unite, of course, and Sepsis, Rory Staunton Legacy Foundation, and the Medical Women's International Association. I couldn't be prouder of having so many colleagues in the room from the Medical Women's International Association. This is a 105-year-old organization, established in 1919 in New York after the Spanish flu. And because of the ECOSOC accreditation, because of the non-state actor status of MWIA, we were able, through the strategic partnerships of MWIA and GSA, to speak about sepsis at the World Health Assemblies and the high-level meetings of the United Nations. Dr. Eleanor Nwadinobi, the president of the Medical Women's International Association. Eleanor.
Good afternoon. Good afternoon. All right. I have a bit of trivia to begin with. What hall are we in today? Eleanor. Thank you very much. We are in the Eleanor Corwin Hall, my namesake. Excellencies, ladies and gentlemen, I am profoundly humbled and immensely honored to be able to make this presentation today. I salute all our partners, and I salute the leadership of the Global Sepsis Alliance, led by our indefatigable Mariam Jashi. I'm the president of the Medical Women's International Association, and our triennial theme is One Humanity, Health Solutions Through Partnerships. Why One Humanity? Is because we are one race, and that's the human race. Why partnerships? I heard a word in a side event by the Global Health Connector this week called Collabo Action, a mix of collaboration and action. So partnerships are important to us. Friends, I stand in the forefront of an army of dedicated women in medicine, some of them in this room. So permit me to acknowledge our President-elect, Dr. Amani Asfour, Mariam Jashi, such a gem to the association as Secretary General. Thank you. We have, I must recognize our Chancellor of the Exchequer, Dr. Eliza Chin. Our United Nations activities are being led by Dr. Connie Newman, please give a wave, and Dr. Bev Johnson. And I welcome all those in this room, and to say that the Medical Women's International Association, we speak up for moving from rhetoric to action to bridge gender gaps in health. Why is that important for us today? Because there's a lot of body of work that shows that in the context of sepsis, women suffer more from sepsis. There are more cases of sepsis amongst women. And therefore, I'm pivoting my talk this afternoon to the fact that women are affected differently, disproportionately, and uniquely. As medical women, we're the drumbeat for advocacy. We speak up for the fact that only 12% of women are in health tech, and fewer are African women like myself. The fact that only 9.7% of funding goes to female-founded health tech startups, and women get less research grants. So if we're looking for research grants as women in sepsis, sadly, women get less. A Deloitte study revealed that women's health represents only 2% of the $41.2 billion in venture funding. Now, when you look at the health workforce, and COVID taught us this, the ILO tells us that 70% of the workforce constitute women. But look at this, as we're talking of sepsis today. When you look at the figures, women live longer, yes. However, they live in 9 more years of compromised health, including diseases that lead to that lead to sepsis. So, dear friends, my message today is no woman should be left behind in sepsis research, but it's not all about emphasizing about the challenges. What are the solutions? Not only should sepsis be on our priority health list, but the impact of sepsis on women. We need to remove the intrinsic bias in how women access information, including information on sepsis. We need to ensure that women are not looked at simply as the different parts of their reproductive organs, but to look at them holistically, not the sum of their parts. When we look at the health research ecosystem, there is a huge, in fact, I would say humongous gap in the stories, the lived experiences of those who have survived sepsis. We want to hear the stories of sepsis survivors, from the stories of those who've supported loved ones who sadly are not with us today on account of sepsis. So those stories should come from those who have seen it, felt it. We've spoken, previous speakers have spoken about this, but I think, as my teacher would say, repetition is for emphasis. My Irish nun teacher would say, Eleanor, repetition is for emphasis. We must invest in women's health. It's a cost-saving imperative. It's a perfect business case, not just a moral imperative. And especially now that we're losing funding and there's seismic shifts around the globe regarding funding, we need innovative and responsible financing. We need pooled investment. We need to look at philanthropy and, of course, private sector with corporate social responsibility. We've heard from Unite Parliamentarians, but we have to realize that it's in the Parliament that we have appropriated budgeting. That's where we have ring-fenced budgeting. And unless and until we have line item for sepsis, then sepsis will not get funded. That's why we need to work very closely with our parliamentarians and legislators. As I close, I'd like to let you know that if you go to the MWIA website, mwia.net, we have a new project called iGLOW, Improving Global Women's Health Through Online Education. Thank you, Alan, for raising that earlier, the fact that health practitioners themselves misdiagnose and miss issues of sepsis. As you mentioned your 8-year-old granddaughter, I remember my 7 granddaughters, and I wouldn't like to be here and hearing news about them being unwell and anything wrong with them not being properly diagnosed. So this online training is contextualized because it's not a one-size-fits-all. The way sepsis is diagnosed, treated, and presents in my part of the world is different to the triage system you might have in the global north. So, dear friends, as I conclude, I would like to say that I'll thank a gentleman who I saw outside the Meath this afternoon, and I said to him, "Sir, could you kindly reach up and get that branch off the tree for me?" And he was taken aback. But he did it anyway. This is the sort of branch in Nigeria, similar, that we get from a palm tree. What do we do with them? We put them together and tie them to make a broom. If you use just one twig to try to sweep, it's not going to sweep clean. We want to sweep sepsis clean. So let's get a lot of strands and twigs and tie them together to make that effective broom. Because it is when we are tied together, we bring all our strands together, that's how we'll be able to do that. I will finish now by saying we'll do it with our elbows locked So I'm famously known by talking about how when we lock our elbows, we form that formidable, impenetrable wall because we're standing together. Thank you for listening.
Eliko, this was the brilliant culmination of the triennial presidential theme, One Humanity, Solutions Through Partnership. And let me also acknowledge Dr. Amani Asfour, our president-elect, who will be inaugurated as the president of the Medical Women International Association in a couple of weeks. In Cairo, we will have the 33rd International Congress of MWIA. Yes. And of course, we will have the pleasure of listening to Amani's presentation in the panels to come. My dearest colleagues and friends, I cannot thank you enough for this brilliant opening session. It was not just the official declaration of commitments, but true support and authentic kind of understanding of the challenge and our shared responsibilities. I really hope that when we come next time to the UNGA, we'll have even a broader audience, a broader partnership, and friends with us to really move forward the agenda. Thank you very much. Please join me in applauding this amazing panel. And our meeting will be getting more and more interesting, bringing evidence, bringing solutions, and the insights from different perspectives. Let me hand over to Ciaran Staunton to chair our keynote presentation sessions.
Thank you.
Fáilte roibh arás a rís, go dtí an seomra sin inniu. Go raibh míle magat. Good morning, good afternoon, good evening, good night, good morning to you around different parts of the world. My name is Ciaran Staunton. I'm here with my wife Orla today. We are the founders of End Sepsis, the legacy of our lovely son, Rory Staunton. Rory died from an undiagnosed and untreated sepsis here in New York City, not far from where we stand today. Rory's life could have been saved. Rory's death was absolutely preventable. When we found out about sepsis sometime after Rory died, and we chose to pursue meaningful, systematic reform in how sepsis is recognised and treated, rather than settling for small improvements. After Rory's death, we built a coalition here in New York State that included New York State Department of Health, the state's hospital associations, Northwell Health, who you see here, and Northwell Health had the gold standard in sepsis, in dealing with sepsis, healthcare. The result of our work was the creation of Rory's regulations, and they were named for our son. Rory's regulations were signed into law by executive action by Governor Cuomo in 2013. They require every hospital in the state of New York to develop and implement protocols to identify and treat sepsis. These protocols ensure the rapid diagnosis and treatment of sepsis with antibiotics and fluids. The latest data we have on Rory's regulations, released by the State Department of Health of New York, show that Rory's regulations in the years 2015 and 2019, in those 4 years, Rory's regulations saved 16,000 New York lives. 16,000 lives alive today who would have been dead but for our son's Rory's regulations. Those, we have met some of them. We have got their texts, we have got their notes. I'm glad they're alive. And New York has set the gold standard in America and in the world, because what it shows is it's proven that sepsis care works. At In Sepsis, we are trying to make sure to make this standard mandatory across the country. Rory's regulations have been the template for other successful regulations or protocols in many states. Right now, they're in a number of states, covering over 50 million Americans. Illinois, Indiana, Rhode Island, Maryland, New Jersey, and many more were all born out of Rory's regulations. But as we focused on state by state, we were steadily gaining traction at national level. A lot of media appearances, a lot of people calling from other states. So we decided we would look at what the federal government were doing. Well, when Rory died, the federal government's approach to sepsis was woefully inadequate, which is to say there was no approach by the US federal government. There was no federally funded research on state of sepsis and its implications for American families or the US economy. There was no plan to reduce sepsis mortalities in healthcare facilities. There was no sepsis quality outcomes. There was no effort to educate families. In fact, when Rory died in 2012, the CDC had absolutely nothing on its website on the A to Z under the letter S. They eventually credited us with getting them to put it on after a lot of knocking on doors and hammering down. To us, this omission cut to the heart of the sepsis problem. It was a crisis most people were doing their best to ignore. But after 13 years of advocacy, coalition building, pressure on federal health agencies, the breakthroughs are finally coming. We have worked with Senator Schumer's office to secure almost $4 million in sepsis for a national budget, with another $5 million for last year's budget. This funding is the first ever funding for sepsis in the United States. It's landmark. And it is to help the United States to fund the CDC's work on the hospital sepsis core element program. After years of campaigning and using the core elements of antibiotic resistance as a model, CDC finally released its sepsis core elements in 2023. And as you most probably know here, that the core elements provide hospitals with comprehensive guidelines to improve sepsis diagnostics and care. To that end, we are working towards the adoption of the core elements as a CMS as condition on participation, which could completely change the US landscape. And just to give you a small picture of the US landscape, when Rory Staunton died, at least 270,000 Americans were dying a year of sepsis. That number is now at 350,000, going up with baby boomers. Finally, in the most recent weeks, we worked with the United States senators to introduce the Sepsis Act into the United States Senate. This legislation was introduced in the United States Senate with something that has support from senators from both sides of the aisle, something that's not going around a lot these days. But we have it, and we will get more. Now, when the Honourable Alan Donnelly spoke earlier, he mentioned through, I suppose, frustrating statistics for most people, but for those of us who buried our 12-year-old son, there's nothing frightening when you, after buying a coffin for your child, nothing frightens you ever again or intimidate you or scare you or keep you awake. But when Honourable Donnelly, I like the name by the way, one of ours anyway, a shortage of 11 million healthcare workers in the world. The only answer to that is OMG, as my daughter might put in the text. And the other one is the lack of sepsis knowledge among healthcare workers and healthcare professionals. Oh my God. Now, part of Rory's law is where anyone in New York are going through have to take sepsis, learn about sepsis. We met the ones that signed off and signed our son's death warrant. But the lack of knowledge among people. Tom Heyman is here today with Sepsis Alliance. And on the last point, he's done a fantastic job on addressing the issue and the area of healthcare workers and healthcare professionals with your annual regular summits, Tom, and I know you'll be talking later, you can talk about it, because we would say in America years ago, there ought to be a law before someone can practice today in any medical or any facilities that isn't addressing, you'll see our brochure there, that the thing that kills more Americans than everyone else, that there are people going into a hospital today that someone said earlier, a blind person could recognize. Now, so well done to Tom and Sepsis Alliance on doing that work. I met Tom on Capitol Hill last week. He, like we do, and we all do, brought families there who had buried children. And buried they did. It's not lost loved ones. They didn't go out and get lost or anything like that. We buried them, and I met the families. And what Tom was doing in Sepsis Alliance was bringing to Washington, to the pulse of the nation, the families that the staffers have to meet and have to keep on to their bosses and our bosses. Why is it, and why is it, and why is it? Because it's not good enough that the cursor is going up in this rich, so-called rich country. You're not rich. So before I wrap up, I will just tell everyone, I think it's on in website, in sepsis.org. You can find out anything. But what I'd like to say to people around the world, the last time I spoke on this, and I think it was in Berlin, it was 172 different countries. So to those or in other states in America, what we have achieved in New York can be achieved in every country in the world watching or listening here today. Rory's regulations are a template to save lives. Save lives for people like Rory and like all the other beautiful children and families in the world who need not have died. Their deaths were preventable deaths. This isn't a toss off the coin. This isn't saying this or that. We now have set that template. It's good enough in 5 American states, and it's good enough it's national, so it should be good enough for people who, whether you're in South America or you're in Australia, New Zealand, or any other country in the world. So it's not why is the question, not why have you not done it, but why not do it? Legislators from all over the world and leaders and world are here today to solve world's crises. buying coffins for our children is a phenomenal crisis that we know how to address and save. There is nothing stopping anyone from your country today doing what we did in New York after we finished burying our son. With that, I'll wrap up. Thank you very much. Thank you. Thank you, my dear. Beautiful boy, a beautiful boy.
It's always incredible, isn't it?
Sorry, my apologies.
Yes, yeah. So, how many times we may hear Rory's story, it's never becoming less painful and less shocking. And special thanks to you and Orley, who became the, yes, Orley is sitting there, for really becoming the warriors, for saving thousands of other lives. And thank you, Ciaran, for, first of all, for making this event happen. And thank you for acknowledging the work of Sepsis Alliance, our second biggest player.
We're all in it together.
Yes.
Everyone's in this together.
And let me also acknowledge Carl Flatley, who was the founding father of the Global Sepsis Alliance, who, after losing her daughter, Erin,
Yes.
became the fighter. Unfortunately, we only start thinking and fighting after the tragedies that should not have happened. And we cannot express enough, really, how we respect, how we admire, and how we are grateful for everything you are doing. So, can we...
Am I back on now again?
No, you're chairing this
Yes.
session, so let us invite your faculty.
Okay, yeah.
Chris Murray, Conrad Reinhardt, please join.
For part of, we welcome our first panel. We will hear about the latest global estimates.
Jackie Duda, please
And
join.
Jackie, sepsis survivor, human face, and also behind the numbers. And we'll take a seat before we introduce. Okay. Our first, I suppose I'll let her down and then I'll ask her to come up to speak. I don't know whether that's. Our good friend Jackie Duda is on the advisory board of Sepsis Alliance. She's a health journalist, travel journalist. She and I have spoken together at a number of events. She has got more energy than anyone else I know on internet, on social media. I don't think she sleeps at all. But without going into her full bio that's already written here, I will save 5 minutes by saying please welcome Jackie Duda.
Okay. Is it on?
Yeah, it is on. Don't leave it. It don't happen to Steve Martin.
Okay, it doesn't want, oh,
It does.
there we go.
you go.
Thank you.
Maybe.
Thank you, Ciaran, and thank you, Dr. Jashi, for inviting me here today. I am so honored to be here to speak to all of you and tell my story. Please pardon my little pun there that sepsis is the writing is on the wall. I am a writer, so I just kind of took a little liberty with using that word. My story began actually 4 years ago. That's how I got involved in sepsis. I didn't know what sepsis was in early 2021. I'm a patient. I do have quite a few NCDs. I have POTS, hypermobile Ehlers-Danlos, which wasn't even diagnosed until I was 54. I have Crohn's disease. I have severe osteoporosis. And because of those conditions, you know, I've been a medical enigma to a lot of my doctors. I actually feel from my medical team, because when I have one symptom, it's not always indicative of what you could find in the textbook. However, in April of 2021, I was in the hospital. I had stomach pain, and a CAT scan showed that I had a thickened bowel. I was seeing a new gastroenterologist, and she couldn't see me until mid-June. In the meantime, the week of May 22nd, I saw 3 of my doctors, as I usually do, as a lot of us chronic illness patients do. We see a lot of doctors a lot of times. And I had a kyphoplasty procedure done on Monday for a fractured spine. I saw my neurologist on Wednesday, my primary care doctor on Thursday, and on Friday I even had a home health care nurse in my home with a home physical therapist. I had severe pain that day in my left hip. And I was also showing doctors how I had this really swollen, hard stomach. My face was really swollen. My neck was swollen like a bullfrog. I was on high doses of prednisone. So that's what that was all attributed to. And I let it go because there were just so many other things going on with me. Until that night I couldn't sleep, and by Saturday morning I still couldn't sleep, and I woke up, or drifted off, woke up around 5 a.m., and I couldn't move my left leg at all. So I woke up my husband, I woke up my youngest daughter, and they called EMS. And here I go off to the hospital again. I'm no stranger to hospitals or ERs, but what happened that morning in that ER has left a profound effect on me. Luckily, despite being a medical puzzle to a lot of doctors, my body decided to cooperate that morning and not hide what was going on. I became a textbook case of diagnosing sepsis. The doctor ignored the pain that I said, I had my left hip. He did a CAT scan of my abdomen, and sure enough, it showed that I had a colon perforation. I went into respiratory failure. I was intubated. The doctors didn't waste any time. And the next thing I knew, they were calling for a helicopter. Once I got to shock trauma, the infamous shock trauma, I call it, in Baltimore, those doctors and nurses, they're amazing. And they took me in the OR despite the fact that I was clinging to life. I was 58 with so many comorbid conditions and drug allergies and you name it. Well, they shoved me in that OR anyway, and they saved my life. But then that was the beginning of the story. That was just the beginning of 2 very long years of recovery. The recovery that I endured was also wrought with a lot of medical trauma. I was not mentally stable. I was very emotional, and I cried every day for at least a year. I went down the Google rabbit hole, and I read what they said about sepsis survivors. In some studies, they're dead within a year, so I thought, well, this is great. I'm not gonna be here much longer. And then I found Sepsis Alliance on social media, which, yes, I'm on there quite a bit. My children joke about putting parental controls on me. But I find out a lot of information. And I found Sepsis Alliance. And then I signed up right away. I went on their website. I signed up for the Sepsis Alliance Connect program. And I learned that they were doing online peer support groups. I jumped right in, both feet, to the survivor group. And that was the right key that unlocked the fear and the terror in my brain, and it opened another door. It was a game changer because I saw people like me in there. I saw people who cried every day, even men who survived sepsis. I saw people who had additional health problems after surviving sepsis. And that's what I needed. That's what I needed to dry my tears, to make me aware that there are nonprofits out there that have our back. And I joined up with Sepsis Alliance to go to Washington, D.C. We were recently there, Tom and I and other survivors, as Ciaran had mentioned, and other parents who've lost children to sepsis. And we were all there advocating on Capitol Hill. So after I was physically strong enough, I started to get more involved in advocacy. I'm now on Sepsis Alliance's advisory board. I also help lead a group for people who survive sepsis and have hidden disabilities. But the big thing that I really wanted to do also was I wanted to tell my story, because a long time ago in my first life as a writer, I used to write for the Washington Post. I used to write for Women's Day. I was out there and I was writing full time. My disabilities cut that short and I hadn't written for about 12 years. So I went to the Washington Post. I found out who the new health editor was. I pitched this story. She green-lighted it. I wrote the story. This was in 2022. And then the editors higher up the chain killed that story. It did not get published until a year later, because I kept pestering that editor. And that's really what it takes. I think that some of the feedback that I've gotten, I've had luck publishing on sepsis. I have 4 articles at least out there and 2 television appearances in a local TV news station in Baltimore. And while I've had those successes, I've had about twice as many declines, or will pass, or no, that will only apply to a certain amount of readers, or sepsis is rare, that's a rare topic, or it's a niche topic. And editors do have a responsibility to try to get, as many readers to click on that article or pick up that magazine as they can. So my hope is that perhaps we could offer seminars or, specifically targeted at editors to help them understand that sepsis is a global public health crisis, to help them understand how many people die, how many children die. It's not just those of us with chronic conditions, it's children, it's healthy people. Editors can, learn a lot from perhaps, just these, knowing what the impact is and recognizing that maybe one article with a list of a top 10 signs of sepsis is not enough if you're only publishing something like that every 5 years. We hear more about cancer in the media, cancer, diabetes, obesity, and other health issues. We can get sepsis in there if we make the tie-in and help editors understand that there's a connection. As was said prior, there's a connection between people with chronic conditions and sepsis. And we don't have to scare cancer patients to do it, like, in other words, saying that, well, if you're taking chemo drugs, you're going to have a decreased immune system response and develop sepsis. As Tom likes to say, we're going to enlighten, not frighten them, and make people aware. Look, I didn't know that that high dose of prednisone I was taking could lead to something like sepsis. My doctors did tell me, just don't get sick. And so I thought that meant a cold. And sepsis is far more than a cold. But I wish that I had been, enlightened about how life-threatening it could be with having my immune system decrease because of the steroids. So in conclusion, that's, my main push as a storyteller, as a writer. This thing happened to me. This thing happens to people I know, and I'm going to talk about it. I'm going to write about it. I'm not going to let go. I'm going to keep bugging editors because they are the ultimate gatekeepers. They give us the green light, and I'm going to keep pitching. But I think we could benefit from helping them to understand more about the impact of sepsis. And thank you so much, everybody, for
Thank you so much. Thank you very much, Jackie. Thank you so much. Our next speaker, and again, instead of reading the 5 minutes on the fantastic bios he has, you'll read it in it. Professor Christopher Murray, Founding Director, Institute of Health Metrics, sorry, I can't say I don't have my glasses. I should have got my glasses on, but anyway, thank you very much. Please welcome Professor Murray. Thank you very much, sir. Thanks for giving me a top package. Tell them what you are.
Thank you very much. Very happy to participate in this event. About 34 years ago, I was asked by the World Bank to quantify what were the leading causes of death and disability in the world. and this went into the World Development Report in 1993. That was the birth of something called the Global Burden of Disease Study, which continues to this day. It was under Gro Brundtland housed at the World Health Organization, and then we've been the coordinating center at the Institute for Health Metrics and Evaluation ever since. Then about 10 years ago, Dame Sally Davies, who was the Chief Medical Officer of the UK at the time, global advocate for antimicrobial resistance, wanted to get AMR into the annual or regular Global Burden of Disease assessment because so many organizations, governments were using the GBD to sort of say what was the order of magnitude of attention that should go to different diseases, injuries, and risks. But what we found out is the first step in trying to understand AMR was to figure out sepsis. And so we did what we usually do in the global burden of disease work, which is look for all the data sets around the world that are either shared by governments or in the public domain or from published studies in the literature, and started to build up what turned out to be a pretty complicated task because the data is pretty patchy in different parts of the world, a way to estimate different infectious syndromes and then who dies from those infectious syndromes, what are the pathogens involved, and then eventually also on to AMR. We published the numbers that everyone's been quoting and that WHO uses for sepsis, I think 11 million. That was back in 2020, thank you, 5 years ago.
Data from 2017.
Yes, 2017 data to train. Now, I'm glad to say that in November, we have the update through 2021. And the update through 2021 is important because the trends in sepsis are fundamentally driven by three different phenomena, and you'll see it in a moment. First, the extraordinary global success in bringing down infectious disease deaths in everybody under the age of 20. And that spans a wide array. It's driven by vaccination, by treatment programs, by improved education of women, a huge array of interventions and strategies. Separate discussion is what's going to happen this year and next year because of cuts in funding. But nevertheless, huge progress in bringing down sepsis and infectious disease mortality under age 20. Second phenomenon is that there's lots more people at high risk of sepsis because of demography. So there's more people over age 70, and the rates of sepsis turn out to be much higher over age 70. And so that is generally just going up. And so we see globally, and you'll see that in a moment, that sepsis deaths over age 50 actually, but particularly over 70 are rising. So you have these crossing trends. And then of course we had the COVID pandemic, which exploded the number of viral sepsis deaths and other sepsis deaths in 2020 and 2021. And this assessment is only through 2021. We see in the data post-21, things have come down from the peaks that you'll see. So here's our assessment. You see the decline in where the underlying cause that shows up on the death certificate is an infection. So those sepsis deaths were going down and then exploded during COVID. And then the sepsis deaths where the death certificate may say chronic respiratory disease or diabetes or chronic kidney disease, but the mechanism of death was sepsis in the blue, and those are steadily rising. What you get to is 21.5 million deaths in 2021 because of the COVID spike. And in 2021, instead of 20% of deaths due to sepsis, we got to a 1 in 3, so actually 31.5%. So a huge surge in sepsis obviously come down, or we expect it to come down in the last couple of years. Now, if you look by age, you get this phenomenon where the enormous surge is 70 plus, and the next big surge during COVID is 50 to 69, but it's not just, this is where sepsis deaths, the underlying cause is infection, but where the underlying cause is a chronic condition, we're here in New York talking about NCDs, then we see this steady rise in sepsis deaths where the underlying pathology is one or several chronic diseases, and that big surge that I described in 70 plus and in 50 to 69. So if we look around the world, because of this mix of childhood infectious diseases and well as the sepsis related to the rise of NCDs in older ages, you get a large fraction of deaths in different parts of the world due to sepsis, but the largest percentages, over 50% in the dark reds, are in sub-Saharan Africa and in some countries in Latin America as well. What are the pathogens involved? Now, this is getting into the details because if you want to think about the research agenda around sepsis and parts of the sort of management, it does matter what the pathogens are. We've seen a very big shift in pathogens in the last 30 years. So back in 1990, the biggest pathogens were strep pneumo. We now have a vaccine, which is pretty good for strep pneumo, and that's brought that way down. You'll see that in a moment. Tuberculosis, lots of progress globally on tuberculosis. And then you get the gram-negative pathogens up here, Klebsiella, E. coli, Pseudomonas, Acinetobacter, and then a mixture of things like Staph aureus and rotavirus. Another vaccine taking rotavirus out of the picture to some extent. So we fast forward to 2021. Now the pattern of pathogens looks different. MTB is at the top, tuberculosis, then Staph aureus and strep pneumo, much smaller than it was, but not everybody's getting the vaccine. And then you have E. coli, Klebs, Pseudomonas, Acinetobacter, and other gram-negatives. So there's an agenda that, especially if you're interested in antimicrobial resistance, but even just understanding the pathogen distribution matters for both new drug development, diagnostics, as well as, of course, vaccine development. And there's good news that there's a number of people now out looking at vaccines for things like Klebs and Acinetobacter as other possibilities, and even some pan-gram-negative vaccine developments that are pretty interesting. So we may have, in addition to just better clinical practice that we've heard about during the day, we may have new tools to tackle sepsis. So that's the update from the quantitative work, and we hope that the huge surge in sepsis deaths that we saw during the pandemic is not going to be continued. But thank you very much.
Thank you very much. Thank you. The next speaker we have has got about a page and a half of a resume, but after today, where we don't actually, I was cutting down how many lines I could read, but he's one of these famous people who now you can just use one line for him. He's like a bit like Madonna or Beyonce or something like this. All we've got to do is say his first name, right? And that's it. Everyone knows what we're talking about. And here he is, Conrad.
Thank you for your kind words, and Alan Donnelly I think is gone or is just outside. Before I start, I would like to mention that I find that this day today is another historic day where we make a difference. Alan, yeah, I just mentioned you criticized in some way that I always pushed and back and so forth and was unsatisfied. But today I think we are entering a new area, not only because we have much, much better data, and I have looked also quite in detail to your wonderful website, also Microbes. I can only recommend it because it's an eye-opener, because it will allow us to compare between countries. And this is the only way to get governments to think why in some parts of the world mortality is half as high, and I'm speaking just on income, etc., etc. So, and there are other topics to be mentioned. Why we are going to have a new era is not only that we are here actually with Northwell Health in 2010. This was a place where we founded the Global Sepsis Alliance. And this is historic, and if I think back, and I will stop now on the history, it's amazing what we really have achieved. Sepsis can hit everybody. Also very famous one, young, old, etc., etc. But as already mentioned, it's really, and this is data from Germany, it's a very young neonates, an incidence in the above 1,500 per 100 population of this population, and it's similar, and it starts to increase. This is the incidence with the age of 50, almost linearly. It's going up in a similar range. And as Dr. Tedros rightly has said, it's preventables, and these are the means: vaccination, clean care, early recognition, management as an emergency. And what is not on there, it's awareness. And if you look at this astonishing data, how did it come that sepsis was no longer on the agenda after 1950? And this has ironically to do with the success which was achieved in the high-income countries. In 1900, the crude mortality rate of infectious diseases / sepsis was 800 per 100,000 population. It continuously decreased by public health measures like chlorination of water, sanitation, etc., development of antimicrobials, vaccines, etc., only interrupted by the Spanish flu. And in 1986, actually, 68, it was as low as 36 per 100,000 population in the US. And this made some people think the book of infectious diseases could be closed. And if you look on this figure now, for the US, between 1980 and 82, it is increased, according to your data, to 200, almost 70 per 100,000 population. And this includes all infectious syndromes. And it's pretty similar high in other high-income countries, like Germany with 247, but in Australia, it's 1/3, it's 109. And I will talk about it later. And if you compare, and if you look what has happened in Australia without mentioning the word sepsis, just by making it mandatory that the hospitals only get certified when there is education of all healthcare workers in the early recognition of deteriorating patients. This made between 2000 and 2012 mortality rate of ICU-treated patients to decrease from 35% to below 18%. And they, using critical incidence reporting and having clinical excellence commissions in New South Wales, when they realized there's still a problem with sepsis, and initiated a campaign which they called Sepsis Kills campaign, mortality decreased below 15%. Between 2023 in the state of Victoria, they had a campaign, Think Sepsis, Act Fast, and mortality decreased from 17.5% to 11.3%, because the number of physicians and patients who were treated along the sepsis pathway increased from 4.6% to 87%. And this went along with a decline of hospital bed use by 3,582 days. And this reduced cost for treatment by 11.7 million Australian dollars, and the cost of the implementation of this campaign was 8.1 billion, meaning a 6-point time of return of investment. coming back, I was surprised on your database to find that the high-income countries in Western Europe, the richer part of Europe, it was as high, similar high, leading even in UK. And to some degree, about 25%, this may be attributable, this was 221, to viral sepsis deaths. But if you look at Finland at the same time, it's much lower. Why? Because they have stronger healthcare systems. They care. The healthcare system is not driven primarily by financial incentives. It's driven by patient safety orientation. And this applies not only for adults or overall. If you look on the, and this is again from their great website, under 5 years of age, any infection syndrome. In Norway, it is almost half as high or considerably lower than in Germany and Switzerland, and in Sweden it's also pretty high. If you look at the United States, it's more than twice as high. If you look at Sudan, South Sudan, it's 1944. So we have conditions which are worse than the US in 1900, just to mention the issue of equity. And we are talking here also on global health. And there's an explanation. This is work that we have done in Europe, a survey by the European Sepsis Alliance, where we ask the question, the hospitals, and this is more than 2,000 hospitals in these various countries, do you have any kind of quality improvement program? Do you spend money on sepsis, etc.? And you see that in the Northern Europe, these figures are much higher than in Western Europe. And thus there is an explanation for these differences. And the great thing of this website is also you can go back for 30 years, you can back to 1990, and you see globally, as you have mentioned, there was progress. There was a decline, and these are various infectious syndromes, respiratory infections or bloodstream infections. Look at Germany. Nothing happened in 30 years. We are a country where our healthcare costs are 40% over the European average, and no country has more ICU beds as we have. So it's not a question of resources. It's how you organize your healthcare system. And only 5%, and this is from the same survey, of hospitals, and be it university hospitals, smallest, have a sepsis-specific program. And to underpin, if you look at the data published in Nature by WHO and look on the ranking of excess death rates during the pandemics, in Australia, New Zealand, there were less deaths during the pandemics overall during the pandemic. In Norway, there was no difference, and this is a kind of factor. In Finland, 2.5, Denmark, 3.4, and then already Germany. We were even somewhat better than Sweden, who has half of the mortality rate of sepsis from other origin. UK, twice as high as Germany, US, 15, Russia, 30, and Mexico, 40. So I'm saying this. Again, what was the difference during COVID? Everybody spoke on COVID. There was in TV, it was on the federal level, it was on the national level. Policymakers took what they need to do to protect their people and not leave a healthcare system on the discretion of interest groups, which is primarily the case in Germany right now. So with this, I finish and go back, was Rudolf Virchow, who was also in the Prussian and German as a member of parliament. He said medicine has an obligation to identify the problem. Politicians and practical anthropologists must find the means to solve it. So this is still true, and that's why it's so important that we have UNITE, that we have ministers of health here, that we have parliamentarians here. This is the only way if we really want to make a difference, and we have data. And thanks again to you, and greetings to Moshen. And when I looked up, to be honest, in, I think, 15 years ago, the global this burden of disease report, I was disappointed because also not only was nothing on the website of the CDC, there was only sepsis mentioned in the report on neonatal sepsis, and sepsis at this time was called a garbage code. And we have overcome with your support. And we are so glad that now on a yearly basis, we are looking forward to have figures on every country. So, and that's why I'm speaking that we are in a new area, and I look forward to the discussions that we will have next year when we have updated data. Thank you so much. So that's why I'm so happy about this meeting.
Thank you very much, Conrad. Two things. Professor Murray, that's excellent work you've done. And secondly, we have Conrad on the record praising you. How many here people get praise from Conrad continuously? The stats from Australia, and by the way, we have Sepsis Australia tuned in down there in the middle of the night, so well done to their campaign. What we're going to do, by the way, there's some coffee, there's water just here behind, and we're going to take a couple of questions for the panelists. I'm going to pass them over the microphone, so if people have a question or so, just raise your hand, identify yourself, and say who the question is for, and I will pass them the microphone. There's a few minutes, we're running a bit behind, but please have a question, raise your hand now. Okay, we'll text you, get the first, sorry, young lady, stand up first, you're first, go ahead.
During the COVID pandemic, 0.1 people died, lived and avoided death. And according to sources, that was because the administration prevented people from coming into the country during the pandemic. So in addition to Norway having a low death rate during the pandemic, I just wanted to point out that also in St. Lucia, they had a 0.1 death rate because they closed their airports and people were not allowed to come in. Thank you.
I think we have text, because next time text.
Thanks very much for mentioning that.
Sorry, the microphone.
In the Caribbean,
It's okay,
I am from Trinidad, went to medical school in Jamaica. And I'll talk to you more about the Caribbean Sepsis Alliance, because I think it's important that St. Lucia participate in it. I just wanted to make a comment to Jackie, and I think that I understand your frustration, and I think we really have to have a concerted effort to get at editors, to get at journalists, etc. We just had a World Congress of Intensive Care in Vancouver last week, and we had a side meeting on sepsis, and there were two women who were afflicted by sepsis, and they had the platform as you have. And both of them stated, which really stuck with me, our problem started not during sepsis, but after we survived sepsis. And one stated that I now have to have chronic dialysis. I'm fighting, trying to not have a kidney transplant, and I need people to help me, take me back and forth 3 times a week. The other one said that I could not work, so I lost my job. Then I lost my house, and for the 10 years I was languishing in the medical system back and forth, I lost the 10 years that I could have children. So I lost this part of my life too. And it really struck me that we have to start sort of saying, yes, that we cannot at the end of the treatment in the hospital just say we have done our job. For many people, that's where it starts. Thank you.
Are there any other questions on the floor? If there's not, we'll move on to the next one. Mariam, you're back. No, that's yours.
Let me invite first of all, thank you very much, Chris, Jackie, Conrad. And the data that IHME has generated has really made the major difference in the fight against sepsis, and we look forward to closer collaboration for the World Sepsis Reports that we hopefully will be able to start with the support of our expanded members and partnerships. I'm delighted to hand over to Dr. Connie Newman, who is the MWI Vice President for North America and our permanent representative to the United Nations. And with this, I hope that finally Tom, Ciaran, American Medical Women's Association, maybe this meeting could be the defining moment for us to really consolidate efforts for establishment of the North American Sepsis Alliance, because this is the only regional sepsis alliance that we are missing. We have all other regions covered, and I look forward to our discussions on that. Connie, please.
I have to hold this. Thank you, Mariam. I want to thank everyone for being here, and I want to thank those people working to help solve the problem of sepsis. I am a professor of endocrinology, diabetes, and metabolism, and I also am the MWIA representative to the United Nations and a vice president for North America. In the United Nations, on the side of the United Nations and also the Commission on the Status of Women, MWIA puts on programs related to health, equity, and gender equality. And in these programs, we often talk about how diseases differ in women and men because of biological sex differences and socio-cultural factors related to gender. And until we really understand how women and men differ in these diseases, in epidemiology, in treatment and prognosis, until we understand this, we cannot treat our patients effectively, particularly women, and we will not reach health equity and gender equality. I also want to say that listening to everyone's talks today reminded me that I lost 2 very close relatives to sepsis. In the late 1970s, my mother-in-law, who was a writer, had written 12 books, who was an artist and an educator, developed lymphoma. And she died not because of lymphoma, because of sepsis related to lymphoma. And thinking of her today, I remember how much she has done for people and for me, and I am sorry, I've never talked about this to anyone. And also later, a favorite aunt who introduced me to 19th century English literature, which became my hobby, died not of leukemia, but of sepsis related to leukemia. So today, we're having a panel, and the theme of this panel is sepsis. I'm trying to read this. Sepsis as a shared public health priority requiring multi-sectoral partnership. Our objectives are to discuss the importance of raising awareness and mobilizing resources for non-communicable diseases and sepsis with a special focus on women's health, and also we're going to highlight lessons from national, civil society, and survivor perspectives. We have several panelists, and I want to, the ones who are in the room, please come up to the table. Who are they? So we have Dr. Amani Asfour, we have Thomas Heyman, and we have Dr. Eliza Chin. Just leave me a chair. That's all. Thank you for agreeing to serve on the panel. The first speaker will speak to us on video, and this is Mariah McKimbrough, who is a sepsis survivor and executive director of Sepsis SIFTUNG. SIFTUNG, did I say it wrong? I'm sorry. Mariah's had a successful 30-year career on the stage, and this was tragically cut short by sepsis, which led to over 60 surgeries, 2 transplants, septic shock, and a coma. Through resilience and a new sense of purpose, she connected with the German Sepsis Foundation and now serves as its executive director. Her new project, which was launched in Nuremberg, is to raise 1 million euros for the World Health Organization's 2030 Global Agenda for Sepsis. So perhaps we can start with her video.
Excellencies, distinguished ministers, colleagues, ladies and gentlemen, I address you today not only as the Executive Director of the German Sepsis Foundation, but also as someone who has survived sepsis multiple times. I will never forget enduring more than 60 surgeries, 2 transplantations, sudden blackout in a moment of septic shock, followed by coma, disability, the need of care, and permanently unable to work. The end of a 30-year career on and backstage. Every success builded as entrepreneur or the head of a state-approved musical academy. Just if life itself had been switched off. Sepsis marked me profoundly, physically, emotionally, and in the way I see the world today. Shockingly, I had to learn that this isn't seldom at all. But thanks to the German Sepsis Foundation, as well as the Global Sepsis Alliance, I found a new purpose and made the decision to dedicate the rest of my life ensuring that sepsis can no longer remain hidden. I want to express my deepest gratitude to Professor Konrad Reinhardt and to Dr. Mariam Jashi for educating, trusting, and enabling me to do so. Without your incredible work and support, I would not sit here today. In this gathering, everybody is aware that sepsis is the #1 preventable cause of death worldwide. Invisible strikes in the dark. I don't have to convince you. So today I want to highlight the other side of sepsis. The needed road of awareness and prevention is still a long and bumpy one to conquer. Every single life saved is worth it. There are 2 sides. For some it's death. For survivors and families, the sentence is lifelong. This is why our mission must go beyond prevention and awareness. We also must improve care during and after the acute stages of sepsis, invest in rehabilitation and support for survivors so they can remain part of society despite disabilities and lasting consequences, which often includes caregiving family members. I'm not a physician, but I'm an expert, as every survivor and every family member affected by sepsis is. This practical expertise is indispensable if we are to build strong international alliances and drive progress within our nations in every area of sepsis. Just a few days ago in Berlin, we made this reality visible in the most powerful way. In front of the Reichstag, under the banner "Sepsis brings death," we brought the coffins. We placed 190 coffins to symbolize the preventable lives lost daily in Germany. This wasn't just another demonstration. This was a symposium for the people. Together with doctors and politicians, we informed, discussed, talked, listened, and took action. We need to reach those unaware of the need to be informed. This kind of health edutainment is underrepresented within the sepsis community. It will never substitute the scientific, academic, and political work needed. However, we need to speak the language of those we want to address. So we did just that. Within less than 2 weeks, over 60,000 citizens in Germany signed our petition for a national sepsis plan in Germany. It marks a turning point. And it demonstrates what's possible when survivors, families, and professionals stand together. Everything I have lived through has prepared me for this mission. I know one thing for sure: tomorrow is promised to no one. Millions of people around the globe will face sepsis in their lifetime, many before they even heard the word sepsis. But it does not have to be this way. We have the data, we have the knowledge, we have the commitment. Sepsis must be recognized as the global health emergency it is. It must be a priority on every national and international agenda, because the urgency we as survivors live with every day must become the urgency with which the world responds. Let us not only ask, could it be sepsis? Let's take the next step, continue fighting against it. So, dear sepsis, your time of hiding in the shadows is over. This is your stage, this is your spotlight, and this is your end. Thank you very much.
I want to thank Mariam McKimbrough for her passionate and informative speech. Our next panelist is Dr. Amani Asfour, who is president-elect of the Medical Women's International Association, soon to be president in a few weeks in Cairo. And Dr. Asfour is a pediatrician and a global leader in women's health and empowerment. She founded the Egyptian Society of Health Awareness, established women's, established women's, where is this? I lost my place. She founded the Egyptian Society of Health Awareness, established women's empowerment networks, and champions girls' education in STEM. I'm going to ask you a question before you begin. Dr. Asfour, building on your experience from Egypt and from Africa and Middle Eastern countries, how can women's organizations and councils advance awareness of policy making around sepsis?
So thank you very much. Can you hear me? It's okay. So I am really honored to be here today with my colleagues of the Medical Women International Association in this very important meeting, because I believe really sepsis within the whole women issues is affecting women more than men. As you all know, it affects sepsis is affecting 48.9 million in the world, but women is more affected with 26 million compared to for men, and also with reference to maternal health, at maternal mortality, it's really affecting 10.7%. So what is really how we are doing it and how can we do it? Because we have seen from one of the speakers that, for instance, in South Sudan, it's 1,900 plus per 100,000 compared to 22% per 100,000 in UK. So it's a huge, huge discrepancy. You asked me about the experience of Egypt. So in Egypt, actually, and maybe across also Africa, because I am also chairing the Africa Business Council in Africa and the African Alliance for Women Empowerment, where we are able to see there is a huge gap within the African continent with reference to the healthcare infrastructure. But in Egypt, we have a strategy, which I call it the triad of empowerment, which really about 3 pillars. The first pillar is promoting health education among grassroots, because it's very important how to promote this health education among the community-based. And in Egypt, we have a very good example at the National Council of Women, where I come from. I am co-chairing the Health Committee. We have 6,000 workers, social workers, that have a campaign which we call it Knocking the Doors. They go to every village, to every family, to every woman, to educate the girl on the whole life cycle. And we send messages with those social workers. Those messages include health messages. And this is again about maternal health, about how they can really educate, how to have build their capacity. And I believe that integrating the sepsis message would be a great opportunity, again, to give it to the social workers who are really knocking the doors and reaching to every single girl and woman in the villages and across the whole over Egypt. So this is one thing that we really need to see, how we build the capacity and how we have a strategy for outreach for the grassroots-based communities. The second pillar is policy advocacy. We need, of course, to see how within the policies we advocate for sepsis, as we have heard together. But in order to do that, we need actually evidence-based, and we need statistics. So we need to have sex-segregated data with reference to the sepsis and how is it affecting women. So when we are advocating, we need to see how it's really reaching out to the policy. And we heard that there is also meetings with the parliamentarians, which is very important because the parliaments have big decisions and they're the one who passing the laws. So again, at the National Council of Women of Egypt, we have all the time meetings with the parliamentarians and to see how through our health committee, we really address what we need to advocate for, and the legislation, like all the other legislation that we have been doing for combating harmful traditions towards girls and women, with reference to, for instance, recently about the cesarean section that is very, very, very high now, how we can lower it. So again, this is a very important thing. The third pillar really is about partnership. And I know my sister, Dr. Eleanor, is about partnership. So how we have this partnership between the associations, with business women, the Women Association as a whole, even business women, because when I started again, another organization, Business Women Association, they don't know anything about health. So we need to see how we have partnership and send our messages not only among us as health professionals, but for other organizations which have outreach to the other sectors. They don't. I was recently in a very, very highly educated woman. She's not in the health, and she was not aware that, she says, my niece is hurting me. She's very young, and she doesn't take any dietary supplements. She doesn't know even about any of those health issues. So it's again a mandatory that we have raising awareness among all our sisters. That's why the role of the women organizations of the National Council of Women is huge, with reference to reaching out to the real base of our communities. So I think this is a very important thing that we can take it over as part of the recommendations. And I think again, with reference to the strap, I don't know if you are going to ask me another question, or shall I go about our strategic partnership between MOA and the Global Sepsis Alliance. I think it's a very important strategy, and I think within the whole global advocacy campaign that I will be happy, inshallah, to take over in October as the International President of Medical Women, inshallah, to see how we put sepsis as part of our advocacy campaign. And to see, again, for instance, in Egypt, we have our Medical Women International Association Congress that will be from 12 to 14 October in Cairo. You're most welcome, all of you, to be there. But one of the tracks, I believe, will be, again, we have a lot of abstracts that's speaking about NCDs and about sepsis. So this is, again, eye-opener because there is more than 600 medical women doctors that will be attending this conference. So again, it's a huge visibility for our, between the Alliance of Global Alliance of Sepsis and the MEWA. And I think through Medical Women International Association, we can achieve a lot by reaching out to all the world, even in Africa, because in Africa we have about more than 20 chapters in Africa, where really we need to have a lot of awareness across the whole over Africa. Even with Caribbean, my brother, you were talking about Caribbean, because again, I just came from Grenada. We had a very big Congress for Africa Caribbean Trade and Investment Conference, and we have talked about healthcare and how we promote our healthcare from Africa and Caribbean, because Caribbean is our 6th region of African Union. And even Professor Dabis, who is the chair of the healthcare, we were there and we saw how we really make this intervention between all Africa and the Caribbean. We share a lot of commonalities. So I think, again, this is a very important about partnership to see how we come together through the Global Sepsis Alliance to have an outreach plan for all the world through Medical Women Association, through Women Association, and again, partnerships with scientific institutions, with other resource institutions to raise the visibility of how sepsis can affect. And we, of course, we heard from my sister as a survivor and from my brother about Rory regulations. So we need to have Rory in every country, and we need to have partnership together. Thank you very much.
Thank you, Dr. Asfour. Our next speaker is Thomas Hanan, who is the president and CEO of the Sepsis Alliance, and he's been the president and CEO of the Alliance since 2013. He has grown its resources, which are now used by more than 2 million people. He launched Sepsis Alliance Connect, Sepsis Alliance Institute, and Voices, training 55,000 professionals and advancing advocacy. A question I have for Mr. Hanan is, how has the Sepsis Alliance positioned sepsis within the wider public health movement in the United States? And please, could you tell us about your main achievements? Thank you.
And Marvin, I used this to, yeah, okay, great. Yeah, I think, you know, we have to look at sepsis as part of a health ecosystem. It does not stand alone, and that's a troubling thing because it is associated with non-communicable diseases. It has after effects, we know, but it's also an opportunity for us to really bring people together. The cancer community, the diabetes community, it really gives us a huge opportunity to think of this as something, the Venn diagram is very rich between this is a health condition and almost every other health condition and every other population group, be it pediatrics, older folks, maternal, what have you. So I think that's kind of the basic answer to that. But I think, you know, in terms of making change happen, we need to make sepsis famous. We need to make sepsis well known. It's ridiculous. Sepsis kills more people than cancer, and the funding for sepsis research and sepsis education is pennies on the dollar. Why is that happening? Cancer has better advocacy. HIV has had better advocacy. We can learn from them, learn from what they've done successfully to flip the equation in the right direction. Encourage you all to take a look at our mnemonic, TIME. Part of the way stroke got to such great familiarity and awareness was through their FAST mnemonic. Simple, easy to use. You can say it's not comprehensive, okay, but it's usable. It's very, very, very useful. And we have it in different languages now, I think in 13 different languages, including Yiddish. So there you go. So we've been around since 2002, actually, when Carl lost Aaron. It was a healthcare-associated infection, but it wasn't the infection that killed her, it was a septic reaction to the infection. And why did this happen to Aaron and not other people who get infections? We still don't really know. There's so much we don't know. But when Carl lost Aaron, Microsoft did not even have the word sepsis in its lexicon. It was a spell check error. That's how far we've come. One of our great accomplishments, I believe, it was in a Northwell facility on Long Island. Conrad, we were there together. 2010, we formed the Global Sepsis Alliance, realizing that borders are permeable, Tex, thank you very much, and that we need to work together as a global community to fight this. So here's what's happening in the US. Very, very common, 1.7 million cases each year. We believe that's an undercount. Very high mortality rate, 350,000 people died. And that's adults only. 6,800 children each year, more than cancer in the US. It's now the #2 cause of maternal mortality in the US, with a disproportionate impact on women of color. #1 cost. We have an administration that's very concerned about money, apparently. So now we talk about money and then the human condition. That's the way they like to hear things, so that's the way we'll talk about it. #1 cost of hospital care in this country. And then there's a huge opportunity with a chronic component here. Sepsis has always been thought of as something that's an acute incident. You live or you die, and that's the end of the story. We now know more and more about this. It's more like it's a chronic condition, and I think that creates an opportunity for communication, for funding, and really building an army of advocates who are suffering with this on an ongoing basis. Disproportionately affects medically underserved community, and that includes lower education, lower income, and less access to care, including limited English proficiency. And we know most patients, as many as 98%, have some kind of a chronic comorbidity when they are struck by sepsis. So NCDs, NCDs account for a large percentage of death globally. We believe that you can't effectively treat folks with chronic conditions if you don't pay attention to infections. Just not going to work. You're going to lose 20% of cancer patients every year, not because of cancer, but because of the infections they get. Same, 60% of children, young adults with sepsis had at least one underlying condition. So there's a real connection here. And cancer survivors have more than double the risk of developing sepsis compared to patients without a history of cancer. And this was in the news just in the past week. A young schoolgirl dies from sepsis 1 week after cancer treatment. My daughter's best friend, age 20, died of sepsis during leukemia treatment. We really need to make the awareness of this much, much higher. So we have some good news, just breaking. We do an annual public awareness survey. You see when we got started, it was at 19%. Fewer than 1 in 5 adults in the US had even heard the word sepsis. Half of those couldn't tell you what it was. We were nowhere. Spell check error, nothing was happening. As Ciaran pointed out, CDC, nothing. Health committee, nothing. No research committees, nothing happening. A little bit of work in the ICU. You see a really dramatic growth as work started to happen in this area. And in this area, Muhammad Ali died of sepsis, so it was a tragic opportunity for us. Patty Duke died of a perforated bowel leading to sepsis, and young Rory died as well. So you see that this is huge, from 19% to 75%. We're talking about 150 million people who have gone from unaware to aware, and now they are able to be educated so that they are enlightened, not frightened, but enlightened. So awareness also very low with antimicrobial resistance. So we know there's a huge connection there that we need to continue to pound the drum on. AMR is a problem largely because of sepsis. So 37% recent survey we did aware of AMR. The good news is when we told them what AMR was, they said, oh, that's really troubling and very concerning, and my elected officials ought to be doing something about it. So very powerful research tool for our policy work. So what are we going to do about it? How do we continue to build awareness? How do we continue to get more resources allocated? Well, we develop campaigns. We treat this like a political campaign. Sepsis is our candidate. And one of the things we're doing, thank you, Dr. Ho, for coming up with this, infection prevention is sepsis prevention. There can be no sepsis without an infection. So if we effectively prevent infections, AKA vaccinations, hand washing, all the good things we know how to do, there will be less sepsis. It won't even begin to be a problem. So we also, very concerned about vaccinations. This is a campaign we just ran in medically underserved communities, Jackson, Mississippi, New Orleans, and West Virginia. Millions and millions of impressions. You can see we went to where the people were, on the buses, in the bus shelters, in the billboards in medically underserved communities. We also, very concerned about AMR, built the End Superbugs campaign. This is run in out-of-home in the DC area during congressional meetings and things like that. We really need to make this a human issue, make sure people understand this as a human issue and not something theoretical like climate change. I'll worry about it when my house is burning down. Your house will be burning down. It's just a matter of time. Same with sepsis. So we have to be creative, right? We have to be opportunistic. In this case, I don't know how many of you know Ronnie Coleman. We now know Ronnie Coleman quite well. Ronnie Coleman is the strongest man in the world until sepsis got him. Muhammad Ali, strongest man in the world until sepsis got him. Ronnie got sepsis, and he says if not for his 13-year-old daughter who insisted that he go to the emergency department. He's like, I don't need to go to the emergency department, I'm a tough guy, I'm big. She said, you're going to the emergency department, Pop. And he said if not for that, he wouldn't be here right now. He realizes how lucky he is to be alive. And he reached out to us, he said, I want to help, I want to do what I can. 12 million followers on social media. When we checked into the Capitol Hill Hyatt, young clerk there saw my ID and he said, sepsis, I know about sepsis. I said, how do you know about sepsis? Ronnie Coleman taught me about sepsis. He knows I can get it in the gym, I can get it in the locker room. Incredible, how quickly that happened. So, things like this are really wonderful, tragic, near tragic opportunities. So, healthcare professionals, that's been talked about also. They are the next line. We send people to the hospital, they get misdiagnosed, we send people to urgent care, we send people, not call 911, and then diagnosis is not made. So we realize that the problem continued beyond just public education. Our healthcare professionals are really unevenly trained. And we did surveys of first responders, of nurses, very uneven readiness when it comes to sepsis. So we started the Sepsis Alliance Institute, where we have actually a conference going on today, 2,000 attendees. Training healthcare professionals across the continuum of care. School nurses, oncology, OB/GYN, camp nurses, ED, urgent care, all the way on through to surgery, antimicrobial stewardship, et cetera. Every healthcare professional needs to know about sepsis the way they know about stroke and MI. There's no other way to go about this. We have now CME accreditation, so we can offer free medical education for nurses, doctors, and allied professionals. Additionally, reach them where they are. We developed a new podcast series. This is on AMR. It's in the top 10 or 15% of all healthcare podcasts now. So a very effective way to reach healthcare professionals. We are already funded for a second season, which will focus on organ failure. So always thinking creatively about how do we get the message out to people. And here we are in Capitol Hill. Ciaran mentioned that. We have everyone from a 19-year-old student from Alabama who survived sepsis, still struggling, formed an organization at her college, University of Alabama, to educate other students about sepsis. Just an amazing young woman. Then we have an older gentleman who lost his wife. So it was really an incredible opportunity. We had, I think, 20, 25 meetings with legislative offices. And this year, in the past, we would go and say, have you heard of sepsis? And they go, I don't know. Well, we're going to tell you about it. This time, almost everyone had a sepsis story. The aide for the Appropriations Office in the House said, I just lost my sister last year. She almost couldn't take the meeting. I mean, it's incredible, incredible shift. We need to keep getting back there. We talked about two things. We talked about the Sepsis Act, which we believe needs to be passed, and Lulu's Law, named after one board member's daughter. Lulu's Law calls for the creation of a National Sepsis Action Plan, as has been called for by the G7 and the G20. Let's get to it. And also the creation of a National Sepsis Data Registry. Like the cancer registry, which really helped us understand cancer is not one thing, but 463 different things. We believe sepsis has Maybe not that kind of heterogeneity, but significant heterogeneity that we do not understand. Why does Rory get a cut and die? Why do I have a cut on my hand now and I'm fine? Why does Katie from our board get a cut and lose her limbs? We don't know. There's so much we don't know here. There's a lot we can do in the meantime, but there's a lot more that we need to know. And that brings us to we just held a symposium in Chicago, 200 leading research experts from across the country. And we're building a research agenda so that we can speak with one voice about the need for more research, certain kinds of research, so we're not duplicating effort, but also more research funding, more policy support, so when innovations are created, that they can actually get into the hospital, they can get into urgent care so that they're used, so that we don't lose young Lachlan DeSantis in Frederick, Maryland, who gets sent home from urgent care saying, it's just the flu, he'll be fine. He dies 12 hours later. If they had a diagnostic tool in that urgent care, Lachlan would be here right now. So much work to do and so much good opportunity. Sepsis Awareness Month, celebrating it today, and all month observing it. And it's just a great opportunity. We also have Pediatric Sepsis Week in April, Sepsis Survivor Week in February, Maternal Sepsis Week in May. So we really need to keep banging the drum. And I appreciate the opportunity to be here for all of you and everything we're going to do together. Oh, I thought it was my makeup. It doesn't want to leave me.
And for your successes in educating people about sepsis. Our next speaker is Dr. Eliza Lowe Chin, who is the Executive Director of the American Medical Women's Association and also a past president of the American Medical Women's Association. She guides AMWA, which is what we call the organization's strategies and programs. Dr. Chin is an author, she's a film producer, and her work highlights women physicians' history and leadership. She has received many awards. So one question I have for you, Dr. Chin, is how can national associations of women catalyze awareness and prevention initiatives on sepsis?
Sorry, which one is this one? Okay, can I move this aside? Okay, thank you so much. Can you all hear me? Okay, what an honor to be here, part of this panel today, and thank you, Dr. Jashi, for including the American Medical Women's Association on this important topic. So my discussion, which I will keep brief because I know we are over time, is to talk about that intersection between non-communicable diseases and sepsis risks, and particularly in women. This is a global challenge. Currently, 2/3 of deaths in women are caused by non-communicable diseases. Of that, heart disease is a leading cause of death in women. And NCDs increase the risk of sepsis in women. So while we've heard a lot of important statistics about sepsis globally in populations, you layer on top of that being a woman, and there are many other considerations related to sex differences and research and bias and stigma and much more. So this opens up a discussion on what are some opportunities for prevention. We've talked a lot about how sepsis can be prevented. And as we look at the population of women, what are some specific issues within our population? There are many social and economic barriers that prevent the diagnosis, treatment of NCDs in women, as well as recognition of sepsis in women. And I was going to talk about them separately, but because of time, I think I'm going to combine them both because many of the issues overlap with NCDs as well as sepsis. So there are social economic barriers with respect to access to resources, what community you live in, what the geography is. There could be financial barriers. There could be access to care barriers. There could be systemic factors that also impact access. There's also a lack of research, research that looks at sex-specific differences and disaggregation by sex. And there's also gender bias. Many instances where women are presenting with symptoms that are different in non-communicable diseases, and they aren't recognized because of the fact that they are women. So that causes delays in diagnosis and access to treatment. Similarly, with presentation of sepsis, women might not have their complaints heard in the same way because of some type of bias. And of course, with sepsis, as shown through that wonderful acronym TIME, you can't afford those kinds of delays. Delays of a few minutes or hours can have a huge impact on the outcome for women maybe being sent home because early signs of sepsis were not recognized. So a lot of potential for education, both on practitioner sides, but as you mentioned, on the sides of patients and empowering women to understand and recognize those early signs. And then, of course, kind of the big elephant in the room, maternal sepsis. Huge problem specifically here in the United States, where our rates are higher than the global incidence, and our maternal mortality rates are pretty much off the charts of what they should be, given the resources that we have in this country. And so there are many issues here related to care during the perinatal period, postnatal period, and maternal sepsis has now been defined by the WHO as the third leading cause of maternal mortality. And of course, specifically in the US, it's a big issue. In 2023, the WHO said that every 2 minutes, a woman dies due to pregnancy or childbirth complications. So imagine the impact of sepsis in that scenario. So moving forward, what can we do? First, we definitely can address some of the socioeconomic barriers that are leading to delays in the proper care of NCDs, as well as the recognition of sepsis. We can integrate NCD screening into maternal and reproductive health care programs. We can strengthen primary care for women and educate women about women's health, as well as systems and other groups. We can fund research that reports data that is disaggregated by sex. We can increase awareness and training on issues of gender bias so that when women present either to the emergency room or to their primary care doctor, their symptoms are taken seriously and they are given the care that they need. We can educate policymakers that the care and the clinical management of sepsis is not something that can be, I need to make sure I say it correctly, that we need to be careful about challenges of imposing legislation on the care and management of sepsis in a negative way. So definitely legislation can be helpful in prevention and getting protocols in place and policies in place to protect patients. But here in the US, we are facing challenges where the intervention for care of sepsis can be hindered by legislative policies depending on where you live, particularly in the area of pregnancy. So we need to really uphold standards of medical care. It is hard for policymakers to understand that you can't define in medicine that distinct point where the woman's health and life is at risk, right? With sepsis, it's not about getting to that point, it's about preventing everything that even to get to that point. So it's about preventing the situation to begin with. We need to continue to invite women leaders and organizations to the table, so I'm so grateful for the Global Sepsis Alliance for including the Medical Women's International Association and the American Medical Women's Association to this. We need to also empower women's voices, both as practitioners, as patients, as advocates, and policymakers, so that they can be the voices to drive this change. And I was so inspired by some of your programs with the US Sepsis Alliance and want to start adopting those within AMWA or partnering with you on those so that we can really get the word out there and address this issue in women. So thank you so much for your time today. Thank you.
Thank you, Eliza. We see partnership in action, and it's delighted that we definitely see the future for the MWA and the US Sepsis Alliance to collaborate on the training of healthcare professionals. With this, I would like to thank again our panel, the first panel speakers. Thank you immensely for all your contributions and the interventions, and we look forward to closer collaboration and further discussions of the issues. Please join me in thanking our panelists. And I'm delighted to invite our second panel representing interventions from academia, to be chaired by my dear esteemed colleague, Dr. Beverly Johnson, MWI representative to the United Nations and the representative of the Canadian Federation of Medical Women. Bev, I will hand over to you so you can invite our amazing speakers to the table.
Fantastic. Thank you so much. And what an amazing afternoon it's been. It's been so informative and so enlightening. And just hearing it from so many different perspectives, I think we will all take home a lot of good knowledge and good approaches to use. I'm a family physician doing clinical work, and I think even with the medical students I work with, asking them that question, can it be sepsis? That's something that may stick with them through their career, and hopefully then they'll, think of this often as they see patients. I do agree that there's probably a lack of knowledge for health professionals. Oh, you can't hear me. Okay, I'm sorry. A lack of knowledge for health professionals, so that's really important for us to consider and reflect on. The power of stories today with Rory and Jackie. Thank you very much for those. And it's great to see the progress in public health associations and the knowledge that the public has about the term sepsis. So we've got our 3 panelists here today, and I welcome them all today, and thank you for coming, and thank you for sharing your information today. And so our first panelist is Dr. Rupa R. Patel, and she's an infectious disease physician from the Washington University in St. Louis. And I have 2 questions for her. What best practices exist for sepsis prevention across the continuum of care from community outreach to clinic level interventions? And how can these lessons be adapted across different resource settings?
Hello, can you hear me? Excellent. And so we've been sitting for a long time. I wouldn't be offended if you wanted to stand up and stretch during my bit. So thank you. It's an honor to be here. I wanted to outline the continuum. I'm going to weave in a lot of the speakers and what they've said today. I wanted to lay out the sepsis prevention continuum and take some lessons learned from one of the fields I've studied intensely, and that's HIV. And the HIV care continuum actually has informed the cardiovascular care continuum and the diabetes care continuum. So when I think about the continuum, I think of the person, the household, the community, then that gets you to the ER, the clinic, and that gets you to the hospital. And I've heard the word awareness 10 times. I kept counting, and then I stopped counting. And I always think when someone's aware and they figure out maybe they have the fever, or they have the early warning signs, then what after the awareness? And those were one of the issues related to HIV. It was the interventions that link you between these steps in the continuum that are just important. The intervention that gets you your transport package, or the hotline to call a patient navigator to help you get from your house and get 3 hours in rural America or rural Bangladesh to your clinic. And so the call to action, the first call to action in this 3 to 5 minute speech is, I think we need to really think about the interventions in between the steps. You can have the best sepsis protocol at your clinic, but if you didn't have a way for someone to go for those 3 buses, or have the phone to get to the clinic, or call a hotline, it won't work, that beautiful sepsis clinical protocol. And some of the interventions we saw is that in hypertension and diabetes, the care packages are now a blood pressure machine, even a phone. Because if someone has a phone, they can call somebody and say, my blood pressure is high, and that's, how do I, take care of it now before I get to the ER, with a head bleed or one of the complications. So I think the interventions in between the steps is what we need to start thinking of. Part of that now is my next call to action, is that cadre of workers that I've heard started with the Honorable Donnelly say, with nurses, I'm going to push the envelope a little farther. You know, there's been a lot of research on community health workers. Where is our cadre of workers for sepsis prevention? And these are persons in the community that can deliver awareness. But one of our lessons learned in a lot of the different fields outside of sepsis and infectious diseases has been the scope of work for these community health workers. When you increase the scope of work so that community health worker can now give the first antibiotic injection after being under supervision and having a protocol, that has prevented sepsis, but also in some cases of pneumonia, etc. But then it's also prevented sepsis-related deaths. And so we have a trove of literature from the 1990s in South Asia of how community health workers were actually compared to physicians and how they administered antibiotics and whether that be an oral antibiotic to, you know, for 5-day treatment of pneumonia in persons less than 5, or a newborn that had early signs of sepsis and they delivered an intramuscular injection. And so we have to have the courage to create the scope of work to be procedural based, and we have to expand it, and this would be in the context of funding cuts today, changes in our healthcare system, they're becoming more brittle as we have conflict. And the one thing that I'm also a businesswoman in this sense, you know, I think we can articulate there's a return on investment when we introduce this cadre of workers. And I want to remind you, it's community health workers, it's medical assistants, it's paraprofessionals, it's physician assistants, and it's nurses. You know, there's a larger, depending on what country you are and you want to tailor it. And I also think it offers the syndemic approach. You know, we heard the journalists say how traumatizing it was to interact with the healthcare system. Well, that's the point of a community health worker. They can help the person wholly and reduce the anxiety, be the buddy system that takes them there. Again, who's taking that 3-hour bus from the salt plains of Gujarat into like the urban area of Ahmedabad, which is overwhelming for a rural residing resident to walk them through. And many of the people we're talking about have very low health literacy, which my colleague Priscilla will talk about. And I think what's great about the syndemic approach is you're tapping into multi-SDG kind of outcomes, and you're tapping into different funding streams where you have resilience of not only the funding for today, but also in the future. One of my last points call to action is one of the pillars of sepsis prevention that starts in the household and the community is vaccine preventable deaths. And we're on the cusp of a new era of misinformation and the disbelief in science. We're starting to see the lowest rates of vaccination in multiple countries with a domino effect. And what is more worrisome is we're seeing Ministry of Health policy now not universally cover vaccines. So all the progress you've made in general, this community, on sepsis, I fear may be counteracted over the next 5 years because we're actually not going to believe in vaccines, and you're going to see what used to be a simple viral pneumonia turn into a deadly ICU hospitalization. And when we look at the continuum, going to my last call to action is, you know, we've moved from household and community, we're in the clinic, and now we're in the hospital. I think all the global health physicians in this room, we understand and we've seen and we've taught about the sepsis protocol and infection prevention. However, one of the things we need to work on is the maintenance and the fidelity to that protocol. Because what we too often see is we have a labor shortage, someone said that, and so with the labor shortage, we have high staff turnover. They haven't gotten their orientation for anything related to this field, including infection prevention. And then how many times have we seen there's no gloves or no bottle of antiseptic for at least a month when you're in rural India, Bangladesh, Pakistan, rural Missouri? We ran out of, during COVID, we lost supply chain. So I think the basics of having the tools that we need and the knowledge we need for the protocol for the maintenance of what we already know. We don't need new innovations. We need to implement the innovations we have today consistently and with great fidelity. So I think in closing, if we take a look at the field level health system and the concrete steps you have to take for sepsis prevention, from the human being to the community to the hospital, and you look at the linkages, I think there's a few call to actions that will help our community actually accelerate the progress we've made on this topic. Thank you so much.
Thank you, Dr. Patel, for your great presentation. And I think your comments about expanding the scope of the community health workers' roles is really important, and that we have to be considerate of the labor shortage as well. So thank you very much. So our next speaker is Dr. Priscilla Rodriguez Armajo, and she's from the Nebraska Medical Center. And the questions that I have for her: we look forward to hearing about your research on communication challenges in sepsis. And could you also share your perspective? How does communication between providers, patients, and health systems impact sepsis and NCD outcomes? Thank you.
Good evening, everyone. It's truly an honor to be here today. I would like to thank all of you who shared your stories. You truly motivate us to do the work we're doing right now. Thank you to the Global Sepsis Alliance and all the other organizations who made this event possible. And my dearest gratitude to Dr. Mariam Jashi for this incredible opportunity to share my voice today. So for a moment, I would like you to engage in a brief activity with me. Pretend you're not feeling well. You're having hard and difficulty breathing. You have a fever. You probably are not thinking very well, and you find yourself in the emergency room. How are you feeling right now? Now I would like you to add an additional component, an invisible wall between you and the provider who's taking care of you. What are your thoughts at this moment? So communication barriers that are extremely relevant, and they're multifaceted. And when we ask patients what is one of the biggest components in communication barriers, they mention language as the biggest one. And this is relevant because we know that nearly 300 million migrants exist currently, and they're probably living in a country where they do not speak the dominant language. For instance, in Canada, 1 in 6 report that they have limited French or English proficiency. In the United States, it's 1 in 12. They cannot speak English properly. So what we know that those patients, those people in the community that don't speak the same language as their provider, which we call language discordance, they have higher rates of non-communicable diseases, of those chronic diseases. We know that when they have those diseases, those outcomes are usually worse. They are non-functional. It's really challenging for them to adhere to the treatments, so they're more likely to not adhere to their medications, to take their insulin, and they have significantly lower rates of cancer screening rates. We've talked about the relationship and the impact that the uncontrolled chronic diseases have on sepsis, and when we add the communication barriers as a factor, that just aggravates that. When those patients get to the hospital, they are more likely to have delayed diagnosis and treatment time. So it takes twice as long for them to actually receive an accurate treatment. And we know that when we take this perspective into sepsis, every 1 hour delay in treatment increases the mortality up to 7%. Those patients that don't speak the same language as their providers, they usually have a higher risk of getting infections, such as the central line infection. And we know that they also have higher risk of having patient safety events, specifically the severe patient safety events, which ends up increasing their mortality rates when they are in the hospital. And if they're lucky enough to survive and get discharged, then we have a completely different scenario. There's less likely to follow those discharge instructions, and not because they have low health literacy in regards to their health, but because most likely the providers are not doing a good job in explaining and understanding what's happening with them, and that they probably need additional information. That leads to 3 times more likely of having unresolved issues, losing follow-up, so they're not scheduling their appointments, they're not following up with their providers. And that leads to unplanned visits in the emergency room. That's extremely relevant in the sepsis realm because 50% of the patients who survive sepsis, they end up having those challenges and having those long-term issues. So we've talked about throughout the day all of the challenges with sepsis. It is a disease that kills the most, but most importantly, it's the most preventable, #1 preventable disease. And then when we add language discordance as one of the communication barriers, that just worsens those outcomes. So what can we do? Here I'm going to echo some of the components that have already been said. It's up to us to really strengthen those health educations, to really empower our patients and the communities to not only understand and be aware of sepsis, but in the timely recognition of those, but also empower the providers, because the burden should not be on the patient, it should be on us to care for them. We need to ensure accessible and multilingual health information, and really ensure that those prevention strategies and the vaccination campaigns, they all account for the language. And here I really want to give a shout out to the Sepsis Alliance for giving us some folders and brochures in Spanish here in the room. We must invest in research. Evidence is the pillar of everything to show not only what is the problem, but to demonstrate the impact and the good that we are doing and how we are changing those numbers and saving those lives. So we need to help to build those robust international registry. Thank you for the metrics that were presented today. And we need to leverage innovation and AI responsibly. And finally, we need to be intentional with the health policies and to encourage mandate and voluntary sepsis data tracking that account not only for the sepsis clinical components, but also for the communication piece of those patients. And therefore, we're going to guarantee that we're providing accessible and accurate care to all of us. So thank you again for the opportunity to communicate about this issue with you today. Thank you very much.
Okay, so thank you, Dr. Rodriguez Armajo, and certainly the information you shared on language dissonance is very important in outcomes and delayed diagnosis and treatments. So our final speaker of this panel is Dr. Asma Syed, and she is Chief of Infectious Diseases at the Good Samaritan University Hospital. She's board certified in infectious diseases. And the 2 questions that I have for her, as the author of the book, COVID-19 Viral Sepsis, what did the COVID-19 pandemic reveal about the intersection between viral sepsis, disparities, and disability? And the second question, how should pandemic lessons inform preparedness for future health crises, particularly in sepsis care? I'll hand over to you now.
Thank you so much.
Well, thank you so much. I hope everyone can hear me. It's good? Okay, great. I want to thank the Global Sepsis Alliance and the Sepsis Alliance and for all the partners here for really having this very important event today. As the last speaker, I am going to try to keep my remarks short. And much of what I was going to share has already been shared, which is, I'm very happy to hear that because the message is resounding and it's, we all have the same thoughts and the same message that needs to get across to the general public and to the masses and to the healthcare industry. So as far as the disparities that we saw firsthand during the COVID-19 pandemic, I think we really were able to see blatantly the decades of disparities that existed in health, both at a local level, a national level, and a global scale. I mean, it was something that just could not be ignored. And what we really saw was that these healthcare disparities that have existed over centuries are really because of multiple variables, whether it's a person's exposure risk, whether it's their underlying medical conditions or their chronic conditions or chronic diseases which are not well maintained. All of those factors really put them at risk of having worse outcomes, and we certainly saw that with COVID-19. And when we talk about health disparities, we talk about a lot of barriers that people have to accessing healthcare. And we did a lot of work on this, on really combating those barriers during the pandemic. I was very heavily involved in Fates for Vaccines initiative, where I was the lead infectious diseases physician and executive member, where we were really trying to reach people where they are so that we could really combat these barriers that are there for healthcare. So when we were talking about immunizations, access to diagnostics, access to therapeutics, access to immunizations, we were really limiting those barriers by setting up immunization drives and centers at houses of worship, where you had trusted messengers really there to speak with the community, speak to people about what is at risk and how healthcare is such a priority. And those are some of the things that we were seeing all the time, front and center, and we continue to see, whether it's locally, nationally, or globally, where people can't have access to healthcare. As Dr. Patel was mentioning, the barriers with transportation, the barriers with childcare, the barriers with elder care, the barriers with financial obligations, not being able to just take off of work because that is going to equate to losing your job, losing your livelihood, losing your home. There are so many things that are there. And when it comes to taking 3 different buses to get to your doctor's appointment only to show up 15, 20 minutes late because the bus was running late, to have that appointment be canceled, it really discourages you from being on top of your health care and from having those chronic conditions maintained, because there's so much at stake for you. So how do we minimize all of that? We have to really work on bringing the health to you and eliminating those barriers. And I'm going to speak a little bit about some of the interventions that we could do with that in a moment. But what I wanted to speak about was viral sepsis and how that came to the forefront during the pandemic. Now, viral sepsis is very much underreported, and during COVID-19 pandemic, it was underdiagnosed, and it really had severe, dire consequences, especially in the very beginning of the pandemic. We saw a significant amount of burden of disease, and people were succumbing to viral sepsis, but it just was not recognized early on. And it was really alarming because, the amount of mortality we had, the amount of disability and death we had, it's estimated that 1 in 6 cases of sepsis was due to viral sepsis. And we know that's an underrepresentation because so many cases were not even accounted for. And what was happening was, by the time that sepsis was recognized, multi-organ failure was already set in, and people were just on that path to having worse outcome. And if they did survive, they were then dealing with the disability, the profound disability that they had as a result of going through sepsis and septic shock and being in the ICU, and the downstream consequences of that, some of which have been shared before, whether it be your chronic conditions that you develop with cardiovascular disease, with kidney disease, or the mental health issues that you have, the post-traumatic stress disorder that you have from being in the hospital, from being in an ICU, and from just dealing with the pandemic, not having access to family or loved ones, and just being disconnected. So there were so many downstream consequences of viral sepsis, and the fact that it was just underreported was something that was a huge challenge, and it really changed the way that we provided care once we started noticing that this was an entity, that this is not the traditional bacterial sepsis that people think about. Then we were able to provide appropriate care for our patients and really save more lives. So that's something that we have to continue to highlight, how sepsis is something that can be seen from multiple different conditions and infectious etiologies, and also non-communicable diseases that are leading to that risk factor for sepsis, right? So if we continue to educate the public and healthcare workers and the industry, I think that's really our goal to come away from this. And the one key takeaway from all of this, I think that we really need to emphasize, is that there's no one size fits all for sepsis, right? The most important thing is that you tailor this towards the individual patient. You have to really be cognizant and really look at the individual patient's risk factors, tailor everything to their diagnostics for that individual patient, to their infection, to what they're presenting with, so that you don't get bottlenecked into thinking that this cannot be sepsis, like we saw firsthand in the pandemic. Now, as far as solutions moving forward with how can we better prepare for future pandemics? I mean, we did a lot of work during COVID-19 pandemic, but unfortunately, as human nature would have it, we have forgotten a lot of the good practices that we put in place, and we're going back to, unfortunately, bad habits and bad practices, and we are not really well prepared for the next pandemic. And we need to bring sepsis to the forefront of that. We have to learn from the challenges that we had, and we have to learn from what are the challenges that the global health community is facing. And the importance in this is continuing to educate, bringing awareness to the general public, to the healthcare workforce, to really show the dire consequences that we have from sepsis and the urgent threat that this faces. And looking at the disparities that are there, as well as, I was happy to hear about all of the comments on women's health and the disproportionate impact on women, because, the title of our next book that my co-editors here with me today is going to be on sepsis and antimicrobial resistance and the invisible threat to women's health. So this is something that we really need to focus on. And I think one way that we can really utilize the tools that we have already is by leveraging technology. Technology is advancing at a very rapid speed. We really need to utilize technology and artificial intelligence to really get that access into difficult areas and to promote health equity, to promote access to medical care, to have these interventions early. So whether it's immunizations, taking care of chronic conditions, and just healthcare maintenance in general, we need to reach people where they are. And we can do that by utilizing the technology that we have at our fingertips. But we want to make sure that we don't broaden the digital divide, right? So how do we do that? We need to make sure that we're investing in funding and financial investment so that everyone can have access. So we build that infrastructure for technology so that everyone can have access to it, so that they can get better health care, whether it's telemedicine or the smartphones or the smartwatches where they have alerts to arrhythmias or cardiac events, MIs, myocardial infarctions, their heart rates going up, first signs of sepsis. How do we adequately and appropriately and very quickly diagnose sepsis and get patients to where they need to be? So we have to really utilize the tools that we have at our fingertips, and we can then really work on shortening this divide that we have on the disproportionate impact of sepsis on diverse communities, including women. Thank you.
Thank you, Uzma, Rupa, Priscilla. This has been an amazing panel. You can stay because I will call our last presenter for today. It's a pleasure to introduce you to Kemi Badamosi, who is the director of the AIDS Healthcare Foundation's Global Public Health Institute for Africa. And she will join the panel as our for the last intervention for today, and we will very soon wrap up. Thank you very much for all your contributions, and we greet all the participants online. We still have the live stream going on. Thank you.
Hello, everyone. Oh, I know it's been a long day, but it's hello, everyone. Okay, so first I just want to say thank you very much to Dr. Mariam and the Global Sepsis Alliance. It's been an honor. I'm here with my colleague Dennis Nazarov, who is our Global Director for Communications and Policy. And I bring greetings from Dr. Jorge Saavedra, who is the Executive Director of the AHF Global Public Health Institute. And Dr. Mariam wanted me to talk a bit about, the links, HIV, which is predominantly our focus, but now we're expanding a lot more into public health, so this also matters very importantly. But I want to thank everyone who has spoken, and it's also the power of storytelling. So just hearing from Jackie, Rory's story, those are some of the things that work in advocacy. And I just want to bring some lessons and insights. It's good that we're having these conversations here, but it's important that it moves beyond here to go down to the grassroots, because that's usually where most of the work is done. And it's one putting the emphasis on prevention. So what some of the advocacy lessons we've learned from HIV, the HIV work. We know that, yes, we still have a while to go, but HIV has made a lot of gains and progress, investments in it as well. And a large part of that is putting the focus on prevention, so whether it's primary, biomedical, but we have to start from prevention. And it starts with simple things as we've heard people talk about healthcare workers. Most of them go into the communities, that's where they are. To what extent are they trained in recognizing sepsis signs, for example? Because HIV, when we talk about the link with HIV and sepsis, is the fact that HIV actually increases sepsis mortality by about 28%. Even in low and income countries, right? And even HIV and TB go hand in hand a lot. And TB is also a leading cause of sepsis for HIV, especially in places where you have high HIV and TB prevalence. So now that we're talking so strongly about integration, which is the benefit of the season and the climate that we're in, it is important that our advocacy also covers issues such as sepsis. So one is the issue of prevention, the need to strengthen that, and conversations around prevention, particularly at community level, but also at facility level. To what extent our healthcare workers trained, and not just in the community, but in the facility. And I see that there is an opportunity even within the HIV space, for example, when someone comes maybe for their routine checks, for example, or they come to pick up their medication. Have we trained some of our HIV care workers to be able to put in conversations on lifestyle, put in conversations on sepsis? So those are entry points and pathways where we can broaden the conversation beyond just HIV to also include sepsis. Because we talk about NCDs now. One of the benefits also of ART is that we're seeing more people live longer lives despite being HIV positive. But of course, the older they get, then there are also issues of comorbidities, there are issues of NCDs. But we also know that treatment as prevention is very powerful. So the more we advocate for people to be on treatment, so that's HIV treatment, for example, the more we reduce their chances of getting infected with sepsis, because we can get their viral loads down, we can get their CD4 to be normal, and that makes it makes the development of sepsis a bit rare. So we talk about that as treatment, as prevention, and that's also something that is very important in our advocacy, and I would like to encourage us, even as we discuss around sepsis, is we need to advocate for care, we need to advocate for prevention, because of course, when people get the treatment they need quickly and timely, we can ensure that more people get to live. Another thing I want to talk about, we've talked about funding a lot, but it's how we go about it. And that's one of the benefits also with the HIV response. When we sit in rooms at national level and we're talking about funding for health, now that we're speaking so strongly about integration, we need to look at the funding for health as a broader pot. Are we making sure at community level, at national level, that when we have conversations on budgetary allocation to health, is there someone advocating that things like sepsis, NCDs, is making its way into those budgets? How can we do that? The power of storytelling, fusing it with the power of data. You create a policy brief. A parliamentarian doesn't know much about most of these things we talk about, but what helps them is that when you, for example, make it into a policy brief. These are things that have worked for us in the HIV response. You get their attention because it is straight to the point, the numbers are clear, these are the challenges. Because at the end of the day, funding is something that has a lot of competing priorities. So we have to make sure that when we're discussing funding for health, it's not fragmented, but we're making sure that the key issues make it to the budgetary allocation. That your parliamentarian, I like the work that you've done with Parliament because that's always important. When you bring the story to them, you bring the information to them, you bring the evidence to them, a lot of them are inspired to move because they can see the lived realities, they can hear about the experience. Another thing I also want to just quickly talk about, we can also advocate for sepsis screening in HIV clinics. That's another pathway. a lot of times when people come for screening or they come for routine checks, can we also advocate that people can have access to sepsis screening, even in HIV clinics as well? It allows us to reach more people, but even those living with HIV, to make sure that they are aware of the signs. I want to talk about patient voices and the voices of survivors. So in HIV, we call them patient voices or patient champions, but they're survivors. And the voices of patients are very powerful. There's a popular saying that you can't argue with treatment. So someone who is on treatment, you can't argue with them because they have the lived experience. And it's just like saying someone who has survived sepsis or who lost a loved one to sepsis, you can't argue with them because they have the lived experience to show that. So we need to have more of those voices in our community, raising awareness, because that's something we can all agree that the HIV community has rested on the back of people living with HIV, going into communities, going into government spaces, going into schools, into workplaces, doing what? Raising awareness, educating people, taking the services to them. And we need to do the same for sepsis. I liked when someone said we need to make sepsis famous. I can't remember who made that statement. I think it was Tom. We need to make it famous, and that's one of the ways. And also media. The media is a key partner when it comes to this. I applaud Jackie's resilience to get her story out. But sometimes we forget that even the media is not as knowledgeable on a lot of these issues as the experts are. So part of what we could help the media with to appreciate the burden of sepsis and the significance of it is we could train them on sepsis. What does it mean? How does it link to, let's say, NCDs, diabetes, HIV, everything else? We need to train the media on that. For us at AHF, something we do well with HIV and the work we do in public health is to do media breakfasts. We bring them into the room. We all know the media likes a cup of coffee and a sandwich just to have conversation about, for example, HIV and how does it affect, or where are we in the world today when it comes to HIV? I think it's important that we take advantage of that, even for sepsis, so that we increase their awareness on it. And that way, you will find allies. We can find allies within the space. They can help advance the story. And let's not forget our celebrities, influential voices. And I think one thing that has also worked is when we identify, and it doesn't have to be someone so famous. It could even be a local influencer who is a popular voice that is respected in the community. We need to bring this information closer to them so that they themselves become champions, even for sepsis, because we've seen that as well in the HIV response. We also need to position sepsis as a health security issue because it cuts across. It has links to a lot of things. So our advocacy needs, and that also feeds into integration. It's a health security issue because if I'm advocating for it, I'm advocating to say that if you strengthen investment in sepsis, if you strengthen focus on prevention, access to care, treatment, and training, you also protect the gains that we have made, for example, in HIV, the gains that we're making in TB, the gains that we're making in other areas of health. So it's drawing that connection to say, when you strengthen this, you're also contributing to ensure that we're not recording any losses. And lastly, I just want to say that, like I said in the beginning, even with maternal health, vertical transmission is something that is still a challenge, I would say, even for sub-Saharan Africa, where I'm from. There's a lot of issues with vertical transmission. We've made some gains, and that's the vertical transmission of HIV from a mother to a child. But we also know that there are challenges with sepsis, right? And, maternal and neonatal. And it's important that even down to, for example, what we have, like the traditional birth attendants, we have some of them in communities where a lot of women prefer to go to the TBAs than to go to the health facility. We need to connect those dots to see that someone like a traditional birth attendant has the basic information and training on sepsis to be able to make referrals, to say if I notice a sign or if you notice a sign, you need to go quickly to the health facility. But also when women come for ANC follow-ups or come for their medication and they're pregnant, we need to train our HIV workers and counselors to, put in there conversations on sepsis, lifestyle, look out for the signs like time, the TIME, I liked it because it's just punchy and straight to the point. Look for these signs, and if you notice any of this, get back to us immediately. So we do have pathways, even within the HIV response, that would also be very beneficial as we continue to strengthen the advocacy around sepsis, NCDs, and I think now is the time to do that, especially with where we are. Thank you.
Kemi, thank you so much for this inspiring conclusion of the multi-stakeholder interventions. 26 years ago, I started my global health kind of work with UNICEF and UNAIDS. And for a couple of years, I was in charge of the interagency coordination for PMTCT with major focus on sub-Saharan African countries, of course. And indeed, we have a huge room for integration. And when we speak about the 2030 agenda and making the next success story in global health, it very much builds on the successes that we have gained in HIV, TB, malaria, immunization, or Hep C elimination initiatives in Egypt or Georgia and any other countries. So I really hope that next year we will not only have this side event in the United Nations under the leadership of the UN member states, including Qatar, Georgia, Egypt, and other member states, but we will also add to the list of the partners logos that we have for the current side event, apart from the, can we move to the, apart from the Sepsis Alliance and Sepsis, Rory, Staunton Legacy Foundation, Virchow Foundation, Global Health Alliance, Medical Women, Sepsis Stiftung, AMWA, and the Institute of Health Metrics and Evaluation, that we will add AIDS Healthcare Foundation and other partners to the list. And since we are convening this event as part of the 2025 World Sepsis Day movement, I would like to take a minute of thanking our very special thanks to all the partners and supporters of the World Sepsis Day movement. Without their support, we would not be able to continue our fight, to continue awareness raising. And again, we would really love to see expanded partnerships, not only private, but non-profit, philanthropic, and public and research foundation support. Because again, every 3 seconds, a person dies from sepsis. A child, a woman, a man. And we have to be more vocal. We have to be more visible in the global politics and the global health agenda. And thanks to all your contributions and support, I'm sure that we will have, the future is brighter, definitely, for sepsis. And I would like to thank each presenter, each participant for your amazing contributions. I think each of us have learned so much from today's meeting, and we hope that our conversations will be even more comprehensive and engaging multiple stakeholders. Ciaran, as the main host of the event, please make the conclusion.
Yes. But thank you very much for everything. You've done a great job. I had a question actually for Priscilla, because you brought up an issue. I'm over 40 years dealing in politics, unfortunately, but you brought up an issue of information, or something along that lines was important, funding for it. Now, the first thing I learned in politics was, how do you eat an elephant? Right? One bite at a time. So if we're meeting with a legislator or around the world, or you're meeting with the government and you give them a big package, saving life is the most important. Information and all those. How do you actually go in and say, well, and the other thing you learned in the room, if you had a magic wand, what would you want? Well, we don't have magic wands. So people going around the world today are going into various bodies. Priority number 1, saving lives. Priority number 2, priority number 3. right? So, but how do we do it? A is to save lives. So we have to get 1, 2, 3, 4 in that order. If we go into a government if we went to Governor Cuomo and said we want A, B, C, and we want it today, we probably wouldn't have had Rory's regulations. Our other states wouldn't have it. So I think, yes, the information is very important, but we have to decide the priority, as far as I'm concerned, as someone who bought a coffin, the priority is saving the life first. The second priority, the third priority, and I think sepsis is not just the elephant in the room, but it is all, it's like what Tom said, it is the famous, and unlike our previous speaker, we have often said when we've gone to Capitol Hill and we've met with people, we haven't had a Rock Hudson. We haven't had an Elizabeth Taylor that'll champion the cause. We haven't had a Hollywood that'll rattle the cages and raise those millions of dollars. When we went into the CDC building, Orla and I in Atlanta many years ago, the first time there was anything ever done on sepsis in the building, there was a photograph of Elizabeth Taylor. There was a photograph of the beautiful young boy called Ryan White. And all of those people, we don't have a Ryan White. Rory's as near as we come to it, that we have legislation, not federal. So going back to your original point, everyone has their own priorities when it comes to meeting. I believe our first priority is to save lives. And Rory's regulations are similar and say, does not cost much money. It saves money too. If we can get that through, then we can go on to bite 2, bite 3, bite 4. Just bring you back to that point. Not I'm disagreeing with you, I'm not getting into a Conrad, I won't disagree with you all over the place. But thank you very much for everything. Just that point. Oh yeah, by the way, before we wrap up, I can wrap up. Thank you very much. Now, oh, but I was going to hand them back to you to wrap up. All right, see you next year within the building, not outside the building. God bless. Yay!